The anesthetist here, anesthetist Dr. Srilekha and Dr. Anbarasan sir in the theater.
நான் வாஷ் பண்ணல, ஃபிக்ஸ் பண்ணிட்டு தான் வாஷ் பண்றேன்.
Probably
Tube
sir
போட்டு
is
fix
planning
பண்ணுறேன்.
to do with the coagulation with the endoscope. We'll be giving a picture through the endoscope.
இது லைட் இதை ஆஃப் பண்ண மைக்கை.
Thank you.
Okay.
Hello. Natarajan sir, Sabri.
Yes, ma'am.
Just intubating the patient. In the meantime, I think we call upon Ratna Kumar from Smith and Nephew to give some introduction about the coablation. Is Ratna Kumar sir there in the auditorium? Natarajan sir, kindly
Yes, ma'am.
coordinate.
Yes. Yes, ma'am. Yes, ma'am.
Okay. Ratna Kumar?
Yes, ma'am. Good morning, ma'am. Yes, ma'am.
Good morning,
Good morning,
Ratna
ma'am.
Kumar. Good morning, Pa.
Yeah,
You
Yes.
just give an intro about the coablation, about the band, and what the things we'll be carrying on while doing in the theater. Okay?
Okay, ma'am. Okay.
To the audience there. Do you have the video play there? Coablation?
Yeah, we have the feed, ma'am.
Then you can start on with the video, just you can play. Even after the audience gather, we can also replay it again if we have the time in between. Ratnakumar, you start playing the audio and you can demonstrate. And when we start here, we'll call you back. So the cameras will be on from here. Okay, Pa. Thank
Sure,
you.
ma'am. We'll wait for that. Okay, ma'am. Thank you.
You.
Presentation start பண்ணலாமா?
Hello, madam. Hello,
Um,
sir. Praveen, sir.
Sanjay.
Praveen, sir.
Hello, sir. I'm hearing Natarajan sir. சொல்லுங்க sir.
Sir, madam, start பண்ணலாமா madam session?
Ask Ratnakumar to present, sir.
Yes, ready, ma'am. He is ready to
they can
present,
go-
ma'am.
You can start, sir.
Yes.
இது யார் ஃபிக்ஸ் பண்ணுவா? கேட்ட டெக்னீஷியனம்மா நீ? இதில் வந்து அந்த ட்ரிப் ஸ்டாண்ட் ஃபிக்ஸ் பண்ண தெரியுமா உனக்கு? ஆ, இதெல்லாம் ட்ரிப் ஸ்டாண்ட் ஃபிக்ஸ் பண்ண தெரியுமா? இதில் ட்ரிப் ஸ்டாண்ட் ஃபிக்ஸ் பண்ண தெரியுதா? வேண்டாம் வேண்டாம் வேண்டாம்.
Training stations over there in India and it's counting. So what is population? Population developed by AutoCAD and is unique to Smith & Nephew. So population generates a precise plasma layer which uses to remove the target tissue with minimal damage to the surrounding area. So logically population என்ன பண்ணும் அப்படின்னா population வந்து ஒரு precise plasma layer வந்து formation பண்ணும். It's high frequency RF generator. So generator வந்து சைலோட ரியாக்ட் ஆகும்போது ஒரு plasma layer ஃபார்ம் ஆகுது. அந்த plasma layer மூலமா நம்ம வந்து டிஷ்யூ அப்ளை பண்றோம். It's not a thermal process, it's a chemical one. டிஷ்யூ மேல பட்டோம்னா அந்த molecules வந்து protect பண்ணி சப்போர்ட் பண்ணும். So population is a word derived from control plus ablation. It's also a pattern word. Writing the word வந்து generate பார்க்க முடியாது. So how population and plasma is formed? So high frequency RF energy plus reaction with the saline and create the free radicals. So we have 4 states of matter: solid, liquid and gas, and 4th one is plasma. So using this plasma we are creating this technology. So this is one its effect on the tissue cell. It will not create any thermal damage to the tissue. It will break the molecules and it suck out the entire tissues over there. So advantages of population: very limited depth of thermal penetration, minimal collateral tissue damage, localized effect, controlled volumetric tissue removal, surface temperature. Maximum of the ablation is 30 degree and coagulation is 70 degree. So temperature compared to other technologies. So population, it's a cold temperature. It's not even class more than 80 degree. Its maximum is 40 to 70. So other conventional costing around any laser, electrical, diathermy is more than 300 or 400 plus. So effects on target tissue: gentle remove dissolution, so that the target for tissue not even grasp 1.2 microns only. Collateral effect: minimal collateral damage. So temperature கம்மியா இருக்கறதால உங்களுக்கு collateral damage ரொம்ப கம்மியா இருக்கும். So population product line today, we have populator 2, controller and branch. These are the set of brands what we are having: EVAC 70, Prosthesis Max, and Turbulate, software, nasal surgeries and laryngeal procedures. I'll explain one by one. Different types of brands. We have EVAC, Prosthesis Group and Reflex Group. In EVAC you have the irrigation port inbuilt. So in Prosthesis Group we have an irrigation port external thing. We have a saline delivery part is something different. And Reflex is a channeling brand. So EVAC 17. We have the features of our vans. Everything consists about ablation, coagulation, irrigation, and suction. So ablation settings, நீங்க எந்த வேன் இன்சர்ட் பண்ணாலும் மிஷின்ல இட்ஸ் ஆட்டோமேட்டிக் இன்பில்ட் செட்டிங்ஸ். அதுவே வந்து 7 and 3 வந்து அக்செப்ட் பண்ணிக்கும். So applications, tonsil, adenoid, any software issues வந்து நீங்க ரிமூவ் பண்ணிக்கலாம். EVAC 17 நிறைய பேர் சர்ஜன்ஸ் மீட் பண்ணும்போது என்கிட்ட கேட்குற கேள்வி ஒன்று தான், எதனால EVAC 17 நேம் வந்து நீங்க வந்து வச்சிருக்கீங்க, நீ டிஃபரன்ஷியேஷன் இருக்கான்னு சொல்லிட்டு. ஸோ 70 இஸ் நத்திங் பட் டேங்கேஷன் ஆஃப் 70 டிகிரி. இந்த டிப் ஆஃப் த பிளாஸ்மா வந்து உங்களோட விசிபிள்னஸ்ல இருக்கணும் அப்படின்றதுக்காக அந்த டிப் ஆஃப் ஆங்கிள் 70 டிகிரில இருக்கும். ஸோ ஆல்வேஸ் அந்த வேண்டோட எலக்ட்ரோட் வந்து உங்களை ஃபேஸ் பண்ண மாதிரி இருக்கும் நீங்க வந்து ஒர்க் பண்ணும்போது. ஸோ Process Max is a surface electrode specially designed for adenoid. Comparatively EVAC விட இது 40% வந்து உங்களுக்கு 33% வந்து சக்ஷன் ரூம் வந்து பெருசா இருக்கும். So that உங்களுக்கு சர்ஜரி லைன்ல பிளாக்கேஜ் இருக்காது adenoid tissue இருக்கும்போது. And this also comes with angulation of 70 degree. And this is surface electrode sir. Comparatively EVAC வந்து உங்களுக்கு triple electrode வரும். நீங்க பாத்தீங்கன்னா தெரியும். So it's a wired electrode. Process Max is surface electrode. So EasyView is designed for nasal JNI procedures. With the diameter of working length is 4.6 mm sharp. So nasal use பண்ணும்போது ஒரே nasal endoscope and van ரெண்டுமே யூஸ் பண்ணுவோம். உங்களுக்கு இது வந்து small diameter இருக்கும். Laryngeal procedures. We have two vans in laryngeal lesions. One is LW and another one is MLW. So working shaft length பார்த்தா 3.8 mm and length 16.5. MLW வந்து ரொம்ப precise and single loop electrode இருக்கும். உங்களுக்கு 19.5 cm கிடைக்கும். So 19 cm up to tracheal third ring வரைக்கும் நீங்க யூஸ் பண்ணலாம் சார். Reflex ultra 45. So term rate channeling van. So usually வந்து term rate ectomy பண்ணும்போது நீங்க வந்து partial ectomy பண்ணுவீங்க, full ectomy பண்ணலாம். இதுல வந்து நம்ம channeling பண்ணலாம் சார் to preserve the mucosa. So submucous reduction தான் இத நீங்க வந்து யூஸ் பண்ணலாம் சார். So 55 is for tongue based channeling. So lingual order reach பண்ண போறதுக்கு we have a marking. So you can see this. இது 1.5 mm ஒரு லிங்கல் ஒரு மார்க்கிங் சார். உங்களால லிங்கல் ஆர்ட் ரீச் பண்ணாம இருக்கிறதுக்கு ஒரு சேஃப் கார்ட் பண்ணுங்க சார். So terminator. So the earlier 145 is a terminate channeling van. This is the terminate submucous reduction van. இது உங்க on table ரிசல்ட் இருக்கும் சார். So that நீங்க உள்ள இன்சர்ட் பண்ணிட்டு ஒரு ஃபிளாப் கிரியேட் பண்ணி terminate இன்சர்ட் பண்ணிட்டு வரும்போது நீங்க ஃபுல்லாவே அப்டேட் பண்ணி எடுத்துக்கலாம் சார். So on table ரிசல்ட் இருக்கும். 45 days you get a result after 7 days, 14 days or 21 days. Depends upon the patient anatomy. And mainly நிறைய டைம் நான் கேஸ் அசிஸ்ட் பண்ணும்போது சர்ஜன்ஸ் இருக்கும்போது டெமோ கொடுக்கும்போது லேட் ஆஃப் ஃபேசிங் திஸ் இஷ்யூஸ் only சார். என்னன்னா இரிகேஷன் கம்மியா இருந்தாலோ இல்ல சக்ஷன் கம்மியா இருந்தாலோ என்ன நடக்கும் அப்படினு தான் மென்ஷன் பண்ணிருக்கேன். இஃப் சக்ஷன் ஆர் irrigation too little, incomplete electrical part. So saline எல்லாம் பிளாஸ்மா ஜெனரேட் ஆகாது. ஸோ irrigation கம்மியா இருந்துச்சுன்னா உங்களுக்கான ஃபுல் பிளாஸ்மா ஃபீல் கிடைக்காது. உங்களுக்கு அந்த ஸ்மோக்கி வேப்பர் கைண்ட் ஆஃப் திங்ஸ் வந்து நீங்க ஓட்டில வந்து ஃபீல் பண்ண முடியும். ஸோ விசிபிள் வந்து உங்களுக்கு நேரா இருக்காது. If too much அதிகமா சலைனா இன்க்ரீஸ் ஆனாலும் அந்த இடம் உங்களுக்கு வந்து கூலிங் ஆயிடும். உங்களோட ஃபீல்ட் வந்து சர்ஜிக்கல் ஃபீல்ட் வந்து கிளியரா இருக்காது. So intermittent electrical path can take steam low இருந்துச்சுன்னா and if high cooling possibilities electrical connectivity to surrounding tissue and suction contributes to clogging and cooling. In case suction வந்து too little இருந்துச்சு அப்படின்னா உங்களால டிஷ்யூ இல்ல அங்க இருக்க ஃபீல்ட் சரியா சக் பண்ணவே முடியாது. So கீப் ஆன் உங்களுக்கு அந்த இடமே வந்து கண்டினியூஸ் பிளாக் ஆன மாதிரி ஃபீல் இருக்கும். So too much இருந்தாலும் உங்களோட பிளாஸ்மாவே ஜெனரேட் பண்ண முடியாது. பேண்ட்ல இருந்து பிளாஸ்மா வெளியே சப்போர்ட் பண்ணிடும். சைக்கிள் பிரஷர் வந்து சக்ஷன் வந்து 300 to 350 இந்த மாதிரி எல்லாம் பெட்டரா இருக்கும் சார் சர்ஜிக்கல் ஃபீல்ட். So that's it. Thank you. Any Q&A sir? So thanks for the time. So we are virtual pattern guides with NSP technology. Thank you so much.
Thank you, Mr. Ratnakumar. That was a very neat and brief explanation about the competition. Thank you. The first procedure will start in another 2 to 3 minutes. Thank you for your patience.
Hello. Hello, auditorium. Hello, auditorium. Good morning, everyone. Hello. Can you hear me?
Yes, sir, we can hear you, sir.
Yeah. Good morning, everyone. I am so happy to start the live surgery workshop here. First of all, I am so happy to be in GMKMCH, which is the place where I got promoted first as a professor, and I was working here for 3 years. Hello? Hello, can you hear me?
Yes,
Hello?
sir. Yes, sir, we are hearing you, sir. Sir, we are hearing you, sir.
Switch off. Off.
காலன் மைக் போட்டுருக்கீங்க போகும் போகும் நீங்க பேசுங்க
Hello. Are we audible, sir?
Hello. Hello.
Sir, we are
Auditorium.
hearing you, sir.
Yes. Uh, Good morning, everyone. I am so happy to come and do the life surgery workshop in the place I got promoted. This is almost like my hometown. All the people in the theater are all well known to me. This from MMC. I'm so happy to see them. And our staff nurse is Papa's sister, who was introduced ENT theater to me when I was here in 2011, and I'm so happy that she's still here assisting me. And then Dr. Praveen. Uh, Praveen was my postgraduate in MMC. When I came here, he was the assistant professor here, and is what sort of a guy he is. He's a wonderful fellow, and more than everyone else, our director and our professor, HOD Krishna Sundari madam. She is, what she has done here is an remarkable job. When I came here, this was almost like a district headquarters hospital. Now I see that it's a cochlear implant center. All these things are all because of the hard work of the madam. So I'm so happy to be among all these people. And before I start this case, I want to congratulate madam for making all this effort and make this as a wonderful place to operate. And I could see, you can see the Zeiss microscope there, you can see a Stowe's camera here, and you see a cobbler here. All these things, a well equipped hospital. I'm so happy. Hello. Hello.
Yes, ma'am. Yes, sir.
Yeah. So with this introduction, we want to show you the setup. So this is the endoscope holder. Okay. So with an endoscope holder, we are looking inside the oropharynx. You could have known a lot of people do a lot of endoscopic ear surgery with an endoscope holders. But I am very skeptical about the use of endoscope holders for endoscopic ear surgery, because that's endoscopic ear surgery is a dynamic surgery where we move the endoscope often. But now with this side, with all this, with the, it's okay. Right. If you have a this is it. So with the endoscope holder, the dynamic mobility of an endoscope is lost when you are doing an endoscopic ear surgery. But that's one of the wonderful tool for the oropharyngeal surgery, particularly for the sleep surgeries, where you can fix an endoscope holder. You can use it both the hands and do well. Okay. So
Yes, yes.
this is an endoscope holder. Then we use this. This is the wand. We call this as a magic wand. Yes, this is a magic wand, where with the wand we do the surgery. The wand is connected with a suction. And where is my control? Wait. Ask somebody to come and keep it here. He can't do that. Ask somebody. Wait. You can see the. Can you hear this sound? Can you hear the sound?
Yes, we are hearing, sir.
So this sound is for
Yeah, the
ablation.
control switch sound we are
This is for the.
hearing, sir.
This is for the cautery. Okay. So coblation
Okay,
will
sir.
give you this sound. So sound konjam korachirunga. Okay. And then if you press, when you connect this to a wand, the cobbler will show you 7 and 3 is the default setting. Okay. 7 and 3 is a default setting. You can see the tip, and the tip you can see two metal rods through which the cobbler flows, and you have holes there. These holes will is used to suck the fluid which is comes out. So you got to irrigate large amount. You can see when you
Sir,
do
we are
this
not getting the endoscopic picture yet, sir.
endoscope picture.
Yeah, we got it now, sir.
Can you see the fluid is coming out? Okay.
Yes, sir.
So this fluid will make the plasma flow and cut. Okay. Then the most important thing in this is that you need not touch and press. Okay, you go near that, it will start cutting. But the most another important thing is, like any surgery, even though all of us would have been done lot of tonsillectomy, we call ourselves as experts in tonsillectomy, but this has got a learning curve. You got a learning curve. Okay, so I am going
Yes.
to.
Sir, it has freezed. We are not getting the voice, sir.
Okay, I am starting the case.
Yes, sir. Yes. Yes.
We start the tonsillectomy from the lower pole. In the lower pole, it is easy to get the plane. Okay.
Okay, sir. Yeah.
You need a brush here, toothbrush. மேடம் செக்ஷனை அந்த இதில் போட்டு நேசல் போட்டு நேசல் பேரண்ட்ஸில் வைக்கணும். இல்லை 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 ஒயிட் கலர் பெரிஞ்சியல் செக்ஷன் கெட்டிட்டர். டேக் த கெட்டிட்டர். ஸ்டாப் ப்ளீஸ். அதே போல் சரி, இது போடுங்க. இதை மாற்றி நீங்கள் வந்து போட்டுருக்கணும். ஓகே, give this. The bleeding what is comes is the place where we have held the tonsil. Okay.
Yes, yes.
The bleeding is not from the dissected side.
Right.
Can you see? Bleeding comes from the place where you held the tonsil, but not from the dissection side. Okay. So this is the plane. Bigger, sometimes you get a big tonsils, you get a bigger blood vessels. These blood vessels may not get cauterized by the coabulator. If that is the case, then you got to use the bipolar, but that situation will come very rarely.
Maybe in adult tonsil, sir.
Big tonsils, grade 4 tonsils, inflamed tonsils might require this sometime, but generally it will not happen. Okay.
Yes, sir. We have lost the feed.
Sorry.
We have lost the feed, sir. The endoscopic picture is not there now. Sir. We are getting only the external camera, sir.
Wait.
Yes.
Sabri, can you hear me, Sabri?
Yes, ma'am. Yeah, now we are getting. Yes.
Got it now?
Yes, sir. We have gotten.
You can see the plasma which is comes out.
Suppose.
You can see there's a bleeder. Okay.
Yes, yes, sir.
You just, as you are doing the case, you can cauterize the bleeder. Okay. We
Yes,
can
sir,
do
yes.
the same surgery with an endoscope or with a microscope. Okay. The problem is microscope is not this much flexible. Endoscope, if you take it in your hands, you can go near, go far, and use it for. Sophie. That's a big vessel which got cut.
Sir.
Pack. Okay. Yeah, go. Straight or reverse. Okay. Okay.
Yes, sir.
No, so actually, the bleeder came behind the tonsil. So once there's a bleeder behind the tonsil, you don't see where exactly the bleeding is. So if that is the case, it is always safer to take out the tonsil and look for a bleeding like this. Okay.
Okay, sir.
So we'll go to the opposite side. Also,
So for coagulation, we have to touch over the surface, sir.
yeah, coagulation you got to touch on the surface,
Yes.
but for the
Ablation,
this
we have to
ablation,
hover.
there's a blue one which you go near that, it's fine. So this is
Yes,
this
sir.
side. Okay, we are starting. One of the Medical College ENT assistant professors are Dr. Ramani Raj, who all of us consider as our teacher. So when he was doing tonsillectomy with the gallbladder in the Stanley, I asked him, "Sir, how do you manage? How many you do with the van?" He said, "Anthony, the best results are on the only first van."
Okay.
Then I said, "What will you do? After doing one case, what will you do?" He told, "I give it to somebody else." So even on when you are doing on the tonsil for the one patient, the best surgery will be come on the first side. Okay, the second side, the van will be slowly becoming less functional. Okay,
But on an average, for how many cases we can use the one van, sir?
use the van, use it sparingly. I mean, in the sense, use in a very limited areas. And you can do it for 3 cases.
Okay,
Okay,
sir.
but if you are doing it extensively, you go inside the tonsil, you do a intramuscular tonsil, that, then it will not come for more than 2 cases.
Okay, sir.
Okay,
Yeah.
so you can see the plane here. This is the plane. Okay, so this, what is bleeding is tonsil. So this is
Sir.
the muscle plane. That's why you don't do straight looking inside, but you can see the plane here better. Okay, and then
Okay, sir.
it is very tempting to take it out fast because it cuts no nicely. But the thing is, you don't do that. Okay, camera.
Sir.
Yeah, okay. You can see the plane now.
Yes, yes, sir.
Okay. So anything you want to ask, you ask me.
Sir, what if we miss the plane and we do intracapsular? If some tonsillar
Sorry?
tissue is left out. What if we miss the plane and some tonsillar tissues left out while doing on with gallbladder?
Nothing will happen. You are not
Okay.
removing all the tonsillar tissue when you are doing tonsillectomy, right?
Yes, yes,
You might
yes.
leave the lower pole, you might leave a
Lower
part
pole,
of a
yes.
tonsil inadvertently or advertently. So all these things, nothing big will happen.
Sir, sir.
Okay. So if you leave tonsillar tissue, fine.
Sir, okay, sir.
Only problem is if you are the if the if you, your visibility is not good, the
Sir.
this thing will get sucked. The uvula will get sucked into this suction, and then it will cut the uvula. You know, uvula has got a good blood supply, so if you cut the uvula, you'll have a little bit of bleeding. Okay, so the case is over.
Very
You
nice, sir.
know, the most of the people will think, pillar detector. Most of the people will think, cotton ball pillar detector. Most of the people will think, why this is very slow, we can do a tonsillectomy faster when you are doing with the ordinary tonsils. But the pain, immediate pain will be very less with the coagulated tonsillectomy. Okay, my schoolmate, he had a snoring. He underwent uvulopaltopharyngoplasty some 15
Sir.
years back. Okay. Can you hear me?
Yes, sir. Yes, sir.
Some 15 years back, he underwent uvulopaltopharyngoplasty. I did the surgery. Okay, when his child developed tonsillitis.
Sabri, can you hear me, Sabri?
Yes, ma'am, we are hearing you.
On behalf of the audience, I put a question to professor regarding which tonsil will be better to do coablation. Regarding breaks.
Yeah, fine. First thing is, who decides the best chances is to do by coagulation? Okay, uh, I'll I am very God fearing person, so I tell God only decides. Okay, so a tonsil which you can dissect nicely, which comes to your hand easily, yeah, it's a good case to operate. This is also not a very good case, what I have done now, but best case is the one you hold the tonsil, pull the tonsil immediately, you see only pillars. So that is like something like this side. It was much easier to operate this side than the tonsil on the left side, because left side was like my endoscope is on from my right side, so it is not very well visible. Okay,
Sir,
so how,
any side preference to start first, sir?
sorry, side preference.
Any
Okay,
any
no,
side preference?
that depends upon this
Nasopharynx?
section.
Okay. Yeah, it's already
Connect பண்றேன்.
connected.
Okay.
It's connected.
You can see the this fossa is whiter. This fossa is little reddish. So reddish fossa used little amount of plasma.
Screen is frozen, sir. We have lost the voice. We have lost the feed. Hello. We have lost the feed, sir.
இந்த செஷன் முடியும்னு சொன்னோம்னா மாடரேட்டர்ஸ்
இந்த செக்ஷன் இது இல்ல இது சார் முடிக்கட்டும், பேசி முடிச்ச பிறகு will conclude. பிரவீன் பிரவீன் ரொம்ப தள்ள வீடியோ தானே பரவாயில்ல, அங்க ஆடியோ தான் சார் பேசிட்டு இருப்பாரு. சார் 70 இருக்கு, 70 டிகிரி ஸ்கோப் ஃபார் வாட் சார்? ஓகே ஓகே ஓகே. இல்ல உங்களுக்கு இப்ப 70 would be fine இது இல்லையா? பின்னாடி ரிட்ராக்ட் பண்ணிட்டு ஒரு ஆர்டரி, சாதாரண ஆர்டரி ஃபோர்சப்ஸ் கொடுப்பா. சரி இது போட்டுக்கிறேன். என்ன சார் வேணும்? திஸ் பேக் பாக்ஸ் இது புல் பண்றதுக்காக வச்சிருக்கேன். ஸ்கர்ட் ஆர்டரி ஓகே. 70 degree scope. Section கொடுத்துருங்க, ஒரு செக்ஷன். Where is it? Straight section. Straight. கொடுங்க. வேண்டாம் வேண்டாம் சார் கட்டுறாங்க. ஆமா
Can you hear me?
Hello, sir. Yes, sir. Yes, sir. Yes, sir. Now we are hearing you, sir.
Yeah, fine. You can. Hello. Yeah.
Yes, sir. Yes, sir.
This is about this is about coablated tonsillectomy. You could have seen that amount of bleeding is very less. You actually. I will say this is an average amount of bleeding. If you do it very well, if it comes out very well, it will be much lesser bleeding. You can see the bleeding point directly then itself. That's an advantage of this coablated tonsillectomy. Other advantages are that one, the patient will have very less pain. I told you about one of my friend who underwent tonsillectomy, and then his daughter underwent tonsillectomy some 3-4 years back. I did a coablated tonsillectomy, and I did it in the morning. After around 12:30, 1 o'clock, we go there. The baby was, I mean, it's not a baby, it's about a 6-7-year-old child who was changed their dress, applied the powder, combed their hair, and prepared to go home. After 4 hours, the baby is preferred to go home. And that fellow was fighting with me. They said, why did you do this surgery for me? When I had a pain for about 5 days, my baby is all right immediately. So amount of the pain will be very less if you do with the coablator. I told you, when you have a less amount of plasma, the amount of post-operative pain will be much lesser compared with that of the white fossa. Okay, so try to use as much small amount of sufficient amount of plasma to dissect the tonsil out, instead of using lot of the plasma and make the fossa very white. The whitish fossa, but the problem with the coablator is that the patient will develop a very thick slough after 5 to 7 days. as you know, the problem with slough is it can get infected. So the patient should have a antibiotic cover for the second week, more, more, more so with that of the other cases. Okay, so you. Uh, the second week you got to give a lot of aerated drinks like Pepsi, Coke, which people like to take. I don't give aerated drinks on the first 3 days because that will irritate, produce gastritis, and the patient might vomit. But after after first week, when the slough is formed, these drinks, carbonated drinks or aerated drinks, will make the slough release faster and come out. So that time, if the slough gets infected, might have pain. Okay, that is, they said the secondary hemorrhage higher incidence because the second week you have second week the slough will be there, and if you don't manage the slough properly, you can have pain, you can have a secondary hemorrhage, but generally it's not required. Okay. Any other doubts?
Yes, sir. Yes, yes.
Hello. Hello, sir. Sir, I am Dr. Sendil from
Yes.
Dharmaburi, sir. And
Hi, Sindhil, how are you?
hello.
Tell me, Sindhil, how are you?
Hello. Sir, fine, sir.
Can you hear me?
Fine, sir.
Yes, yes, yes.
Fine, totally fine, sir. See, sir, I can hear.
So,
Yes, here.
yeah.
Can you hear me, sir?
Yes, yes, yes. I'm hearing you. Tell me.
Hello.
Yeah, I am hearing you, Sindhil. Tell me.
Sir, it is sir, the surgery is very fine, sir. And
Thank you,
I
thank you,
question,
thank you
sir.
very much. Yes.
Sir, me by coagulation. So, is it advantageous to intracapsular because of the advantage of coagulation?
I'm sorry. I'm not able to hear you.
Because
Correctly.
extracapsular we are doing with the coagulated intracapsular tonsillectomy.
See, this is not intracapsular tonsillectomy. Intracapsular tonsillectomy is you leave you don't remove the capsule. You remove only the tonsillar tissue. Actually, intracapsular tonsillectomy or the tonsillectomy is done for grade 4 tonsils, where they used to tell, a lot of pediatrician always tells you that when you do a tonsillectomy, the patient will go for immunological problems and patient develops this, that, and things like that. They said that tonsil is a defense mechanism. You remove the tonsil, the patient loses the defense mechanism. Okay, so when you have a grade 4 tonsil definitely produces problems like obstructive sleep apnea. As you know, only absolute indication today for tonsillectomy is the obstructive sleep apnea. Okay, so you got to remove the tonsil and make the airway better. Chronic dysphagia will produce failure to thrive. The patient will be very small, puny babies. And second one is long-standing obstructive sleep apnea. The patient can go off anoxic carpulmonale. Okay, to prevent these things, we got to do, these patients should undergo these patients should they remove the part of tonsil, leaving behind little bit of tonsillar tissue. That is what is called as intracapsular tonsillectomy or tonsillotomy. Okay, so tonsillotomy is different, but this is almost you leave behind the tonsil and take out you leave behind the capsule, is the sense that when you can identify the tonsillar tissue and remove only the tonsillar tissue, leaving behind the capsule. But this doesn't exactly is a intracapsular tonsillectomy or tonsillotomy. But the same amount of bleeding and the results will come when you do it with a laser or you do it with a other thing like harmonic scalpel. Okay, but the thing is, coagulator is the one which is available to us and is cheaper. You compare with that other vans, this is cheaper. You don't, the laser will cost you, good laser will cost you about 70 lakhs to 1 crore. But this is cheaper. That's an idea of doing with the coagulator than using coagulator as a primary tool, not because it's got any other big advantages. Okay. Yeah, it's stupid.
Okay, sir. Thank you.
Any other doubts?
Hi, sir. Sir, some
Yes.
words of complications.
Sorry?
So something about post-op complications. Post-op complications, sir.
These patients. So that's what I
Sir,
told you.
can you
The
hear me, sir?
complications, yeah, I can hear you. The complications comes because of the slough which occurs more prominently in the after 5 days, not because of the tonsillar surgery per se. Okay, so you give a good antibiotic for the second week also, and remove the slough by using good goggles. Then and make the patient swallow better. The incidence of secondary hemorrhage is not as high as that of the what it is told in the primary papers when it comes immediately after the advent of coablator started using in the tonsillectomies. Mostly these papers come from the Western countries, particularly UK. But over the period of time today, they do most of the surgeries under with the coablator rather than doing it the cold stale, due to the advantages of decreased amount of bleeding and the decreased amount of bleeding and the decreased amount of bleeding and the less amount of pain related post-operative morbidity. Recently, some 1 month back, I saw a patient it's about uh, severe sleep apnea. You can see baby is struggling to breathe. But the baby is about 2 years and 2 years and 3 months, and the weight is about 10 kg only. Okay, but it's an ideal case to do a tonsillectomy for obstructive to sleep apnea. When the baby is sleeping, you can see all the classical signs of struggling air hunger. You see the intercostal muscle indrawing and severe retrosternal suction. Baby is straining, opening the mouth, and a large amount of sound coming out. And so I did a coablated tonsillectomy. It's as the baby is smaller and smaller, the amount of tissue fibrosis will be lesser. So it takes less amount of coablator plasma to dissect the tonsil. We have done the case and sent the patient home the next day without any problem. As you can see, a huge tonsil, huge big tonsil. Afternoon we have a case of grade 4 tonsil. So huge big tonsils are when the fibrosis is more. For example, adult tonsils, the amount of plasma required to dissect out will be more. So when the fibrosis is lesser, you can dissect it out faster, so that what we can see is you can do more safely with these patients. So bleeding, secondary hemorrhage is what is always pitted against the coablated tonsillectomy, which is because of the poor management of the slough which is coming on the second week. Okay.
Okay, sir.
But the problem is,
And
we
which
have
hand you prefer?
you saw today I did know with you do it with the left tonsil. I use left hand, and right tonsil I use right hand. But you can even, like how we do tonsillectomy, you can cross, but it's only how you get trained. There is a proper way of doing it, like you're holding your endoscope. Everybody hold endoscope in different ways, right? But you got to learn
Yeah.
how to do it properly at one end. Other end is how to do it conveniently. If you have learned your surgery and you know how to
Yes,
do
sir.
your endoscopic nasal and ear surgeries, once you have learned the surgery proper, holding endoscope in your hand doesn't matter. But if you want to know, for example, somebody is seeing me operating
Okay,
and
sir.
you telling me, sir, why don't you use the left hand for the left tonsil? For that, you should learn that also. The proper way to do is left hand for left tonsil and right hand for right tonsil. But you can still cross the hands and you can do it. Particularly with the microscope, it's fine. But an endoscope will be jetting out, so you can't come very far off. Somebody is pressing. Somebody is pressing the. Sir, maybe it's fine. I am removing. Thank you. Thank you. Again, thanks, sir. Thanks, ma. Thank you. ஏம்மா அதை எடுத்துருமா ஆஃப் பண்றேன். ஹலோ ஹலோ
Yes, sir.
Any questions?
Yes, sir.
So,
We can
so
hear
again,
you.
I thank everyone. Again, I thank everyone for giving me the opportunity to operate in the place where I started, where I got, when I came here as a professor. So I can see all the great faces here, and I can see Kavita. Whenever this place is, most of the people will tell Coimbatore and Madurai are good for non-veg food, but I prefer Salem because Salem has got a fantastic blend of spicy to the non-spicy food. And whenever I think of non-veg homemade food, first thing which come to mind is Saravakumar and Kavita. So even today morning they have literally pressurized me to come and have the breakfast in their home, which I know the huge banana leaves is full of non-veg food. But because I need to come here, really, I couldn't go there. So, except Kavita, everybody is here. So the Praveen is here, the fellow whom I hate to go and eat with because he eat only sort of 1/4 of what everybody else is eating. And so seeing everybody, I'm very happy. I could see even Shankar there. Hi, Shankar. And our Sangha Talaivar. So I'll go change and come down for inauguration. Hey, good morning, Kavita. Sorry, Professor. Good morning, Professor. How are you, Professor?
Sir, sir.
Professor, how are you?
Thank you very much for your compliment, sir. Today you should not miss it. We are waiting for you, sir.
8 o'clock I was here. No.
Thank you.
Thank you, Kavita. Thank you very much. I'll go change and come down there to meet you all.
Okay, sir. Waiting eagerly, sir. Bye.
Hello.
Now I cast Dr. M. Kavita Madam, Associate Professor, Department of ENT, GMKMCH, to present the mementos to our moderators, to Dr. Sabari Rajan Sir, Secretary, AOI, Salem Branch.
I welcome Professor Dr. Anthony sir, Professor Dr. Krishna Sundari madam, HOD of ENT department.
I welcome our Dean sir. I welcome our MS sir to this event.
A very good morning to one and all present here. I welcome our Dean, Honorable Dean Professor Dr. R. Mani sir, Medical Superintendent Professor Dr. P.V. Dhanapal sir, Vice Principal Professor Dr. M. Tenmuri madam, the guest of honor for today Professor Dr. Anthony Irudharajan, Professor of ENT in MMC, and the President of AOI Chennai. I also request the HOD of Department of ENT, Professor Dr. M. Krishna Sundari ma'am, the Secretary of AOI Salem, Dr. P. Sabrirajan sir, Associate Professor, Department of ENT, Dr. M. Kavita, to take up the seats on the dais. Hello. I also request the AOI Treasurer, Dr. Raj Tilak sir, and the Joint Secretary of AOI Salem, Dr. Shanti madam, to take up the seat on the dais.
தமிழுக்கும் அமுதென்று பெயர், அந்த தமிழ் என்பத் தமிழ் எங்கள் உயிருக்கு நீர். இவ்விழாவிற்கு வருகை தந்துள்ள அனைவரையும் தமிழ்த்தாய் வாழ்த்து பாட எழுந்து நிற்குமாறு பணிவுடன் கேட்டுக்கொள்கிறேன்.
சித்திராரும் வதனமென திகழ் பரத கண்டமெதில் வெற்றிகளமும் அது சிறந்த திராவிடர்கள் திருநாடும் தக்க சிறு திரை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரமை ஸ்திரம் வியந்த செயல் மறந்த வாழ்த்துமே வாழ்த்துமே.
Now, I kindly request our dignitary, respected Dean Sir, MS Sir, Vice Principal Madam, and our guest of honor, Dr. Anthony Sir, RMO Sir, to give this workshop a beautiful start by lighting the Kuttuvelakku. Please, sir. I also request Dr. Shanti ma'am to join.
Thank you, ma'am and sirs. Welcome address and சொன்ன
to arrange and coordinate a live surgical workshop. These are all possible only with the help of our administrators. Respected Dean, Professor Dr. Mani sir, a person with the diplomatic administrative skills. Welcome, sir. Respected MS Professor Dr. Dhanapal sir, I am very happy to say that he is our observer for this live surgical workshop appointed by MGR University. Beloved VP Professor Dr. To do in a motherly heart. Professor Dr. Anthony sir, a person with the extraordinary surgical skills, memory, and is a great teacher, which every one of his students admire, including me. And he has pulled the audience from various districts to say. Associate Dr. Kavita Madam, a person who stands with me in all my aspects of administration. Okay, ma'am. I have a bearers, Dr. Major Sabri Rajan, Secretary, Dr. Raj, Treasurer AOI of Salem, Dr. Shanti Madam, Vice Secretary AOI Salem, and all the AOI members of Salem who are present here. Even though professors, HODs from the anesthesia are not here, they are all held up in the theaters. I take this occasion to inform that they have been doing a great work, and today it's their main participation in doing this live surgical workshop. Our senior ENT professors, Dr. Lakshmi Narayan sir, Dr. Premnath sir, who is sitting in the first row. I am very happy to invite them, and for every department, they'll be here as a family. Thank you very much for being here. And all ENT surgeons and posts from various medical colleges and district hospitals, I like to mention, I'm honored in mentioning them. From Vinayaga Mission Medical College, Government Dharmaburi Medical College, Government Medical College Erode, Melmaruthu Adipura Medical College, Rajiv Gandhi Government Hospital, Government College Bangalore, Medical College Vellore, Government Medical College Trichy, Government Medical College Kalakurchi, Government Medical College Namakkal, ESI Salem, Velamal Medical College, Karpagam Medical College, Apollo KJ Hospital from Ranipet, and district hospitals from Attur, Omulur. I'm very happy and inviting you all to this occasion. And above all, my dear PG students, CRRI, and UG students, and grade 1 matans and staffs and paramedical who have been working for nearly a month to make this program a success. And I'm also bound to mention Mr. Bhavinashi and team, Smith and Nephew, Mr. Ratnakumar and team of Microlabs, Mr. Shakshi and team of Sun Pharma, Mr. Satyanarayan and team Medifocus, Dinesh and co of Philips Restaurant Division, because they all have been working with us for the past 2 weeks. Because we have to do a sleep study, dyes, and a lot of procedures, we have to prepare the patients pre-operatively, and they have given the fullest cooperation, and welcome you all. Thank you very much.
Thank you, ma'am, for your sweet welcome.
Association of Otorhinolaryngology of India, Salem branch, has been creating a great learning platform in the academic growth for young budding ENT surgeons. It is our greatest pleasure to invite Dr. P. Sabarirajan sir, the Secretary of AOI Salem, to give us all an introduction about the live surgical workshop it is being held today. Please, sir.
Good morning, ladies and gentlemen. We are happy to welcome you all to this live surgical workshop arranged by Government Mohan Kumar Mangalam Medical College and AOI Salem. Science is ever evolving, and so the learning is. As we all know, the coablation technique, which stands for controlled ablation, uses a frequency current which passes through the active electrode and it was already discussed, when it enters the crystalline fluid, it breaks the molecules in saline, it ionizes and creates the plasma field. So the main aim of this workshop is to learn the pitfalls and clear our doubts about employing the coablation technique in right indication, and improve ourselves in our day-to-day practice. And so the interesting part of this technique is as the coablator person has already discussed, the depth of penetration of this plasma field, which is very less, which is around 200 microns, and the temperature produced, which is around 40 to 70 degrees Celsius in comparison to other conventionally used electrocautery, which goes around 400 to 600 degree. So you can compare the lateral collateral thermal damage, which will be very less, and in turn the morbidity will be very less. So this is the crux. And as with any new technique, many of us initial glitches, initial starting troubles for this technique also. So from experts, we want to learn, evolve, clear our doubts, and improve ourselves through this platform. So we eagerly look forward, welcome you all again into this workshop on behalf of AOI Salem. Thank you.
Thank you. Thank you, sir, for giving us all an insight about this topic.
So one thing I want to announce in this auditorium, we have 2 coablations in our GH, but even sir, before coablation was brought to the GMKMCH, when Professor Anthony sir was here in 2014 to 16, I think he was here for 4 years, he brought his coablation from Chennai, sir, to demonstrate for us. It's around 10 lakhs of the instrument, with every band will be around 12,000 or 24,000. And he used to bring everything for his students. Even today, if I ask, he'll be bringing, sir. He's such a great teacher. I have to mention it. Thank you, sir.
I welcome Professor Dr. Kyle Willy ma'am, Chief of Anesthesia, Professor Dr. Subha ma'am, HOD of OBGY, and Dr. Nirmala ma'am.
I now call Professor Dr. Thenmozhi Madam, Vice Principal, GMKMCH, and constantly engaging and supporting all our initiatives.
This live workshop, and my hearty thanks to Dr. Anthony Irudaraj for having come here all the way, not forgetting the previous station, to demonstrate and update the young PGs and upcoming ENT surgeons. Wishing the workshop success.
Thank you, ma'am.
I now call upon Professor Dr. P.V. Dhanapal sir, the medical superintendent, a man whose wisdom and smile is always a source of encouragement to all the budding minds. I welcome you to deliver the speech, sir.
Good morning to one and all. Respected, beloved, dynamic Dean of GMKMCH, Professor Mani sir, and respected Vice Principal, Professor Thenmozhi Madam, and the eminent ENT surgeon, ever helping hand to GMKMCH. My friend Professor Anthony sir, not only is academic, in all the ways helping to students everywhere in the entire Tamil Nadu. So, and any help in ENT consultation is ready to help anywhere, anytime. So that's a great person. Today, we are all, our postgraduates are so lucky today. And our HOD of ENT, Professor Krishna Sundari Madam, and our Associate Professor Kavita Madam, and Erode Medical College, Madam HOD of ENT Kavita Madam, and on the stage, my senior in Stanley, Dr. Sandhi Madam, and the associate of Professor Dr. Sabri Rajan, RNC Secretary, Dr. Kavita, and all other team, and associate ENT faculties, and also our state president, Anthony sir is state president also. And I am so happy that even though retired from the GMKMCH, still they're pillar of our ENT department. I am still remembering 2008, Dr. Premnath sir, HOD sitting here, as a senior, very senior HOD. As a single person doing all the surgeries, managing the department, he is also a participant today. And our senior consultants are also here. And other from ESI, Madam Soba and other thing, and all the faculties, I think all private consultants sitting inside the hall. I got to thank the Professor HOD collecting entire private and government setup, all the ENT doctors, for the very useful live workshop. On behalf of Tamil Nadu Medical Service, Tamil Nadu Medical Council has given the credit hours 2 hours. So that also matter took every steps to get the credit hours. So you have to entire department, especially Dr. Praveen, a senior assistant professor, and Magendran and Nadraj, and all other faculties, Professor Raj Tilak. I have to mention each and every one, and especially postgraduate Niveda, Sasikumar, Sanjay, Rogani, Uma Maheshwari, all are working team. As a medical superintendent, if I fail in my duty and not mentioning, during COVID pandemic, they done excellent mucormycosis surgeries. We had to appreciate on behalf of GMKMCH. Because everywhere there issue, they took day and night surgery, they reduced the waiting list, they done excellent surgery in spite of hurdles and routine aspect, the duty also. I think only the 4 assistant professors here, 2 chief with the short manpower, they done wonderful, nearly helped 8 districts. All mucormycosis cases referred to only here. We separately created ward also. And also, I got to appreciate the Dr. Premnath started the developing department, followed by many HODs came, like Madam Prem Kumari and Ravi sir came also. Then Talapati Ram Kumar, followed by our Kisundari Madam. So everyone they done excellent work in developing the ENT department. Especially Madam got the PG, 2 PG seat, no, 2 PG seat for a year. For that, she will fight in the insurance meeting to give a lot of money. I think she got a lot of money from the administration for the development of the ward, and especially they got separate OT. In spite of a lot of hurdles in the OT, they developed separate OT. The MOT converted to ENT OT from live workshop going, I think, from MOT. So for every steps as a team involving all the assistant professors and PGs, Madam is always from observing from the Dharmaburi also, she's working Dharmaburi also with me. So on behalf of the administration, I appreciate our HOD, Kisundari Madam, and this sort of live workshops should be useful to all, not only government setup, for the private also. So I request the Madam to conduct many more workshops in future, at least monthly once, with involving Anthony sir help. I think Anthony sir always ready to help us. I still remembering when I was assistant professor, sir, as a chief, you'll go to OT and you talk to the students and teaching while walking also. Is going on. Then you took a canteen for all. So such a entrepreneur also is not only academic, the good hospitality also the Anthony sir will have. So I am still remembering. So that's I think the success story of Anthony sir. So now academic, hospitality, and all the way. Anthony sir is so helpful to please always give helping and continue your helping hand to GMKMC sir. You know, we got the state second rank in performing the overall medical college. 37 medical college. The Salem stood for the second rank in performance all surgeries. So I have to appreciate our beloved Professor Dean sir. He took up 6 months back with the dynamic leadership, with coordinating with all the HODs. He's done with this short time, 6 months, done lot of work, not only civil other work, academic and all infrastructure work, medical NMC work like that. So I have to, on behalf of you all, I appreciate our beloved Dean Mani sir. Thank you for giving me this nice opportunity. Thank you all.
Thank you, sir, for your enlightening speech and kind words of appreciation. Next, I call upon the guest of honor for the day, Professor Dr. Anthony Irudayarajan, sir. Besides perseverance and hard work, pioneering spirit and the willingness is the alchemy of an achieving person. We are so lucky to have him with us, despite the distance and his hectic schedule. I am honored to introduce the very prolific and the generous chief guest, Professor Dr. Anthony Irudayarajan, sir. He has 25 years of ENT surgical experience and training the PG student. He has done over 3,000 endoscopic ear surgeries and more than 4,000 FIS since 1992, and more than 550 head and neck oncological surgeries. He has delivered the invited talks in the first World Congress of Endoscopic Ear Surgery. I am very privileged and to introduce our chief guest. I welcome you to deliver your speech, sir.
Respected Dean sir, respected medical superintendent sir, respected RMO, and the big professor of ENT, the HOD, Professor Krishna Sundari madam, and dear friends. I know it is not easy to create a department, upgrade the department, and make the department work in such a way that it becomes second best in the state. So for that, the credit goes to everyone, from the administration to the HOD, to all the faculties, and also to the people of GMKMCH. First of all, I congratulate everyone. When I came here, we don't even had a building. We don't even had a separate theater, and no big instruments here. From that state, from today, you have every state-of-art instrument in GMKMCH. You have the best microscope. You have the best endoscope and the instruments. You have coagulator. You have debrider. Everything. It's all because of the hard work of the madam. And when I came. Sorry, Praveen, but now you understand what is the advantage of having PGs here. When I say we start PGs, you say, sir, vana sir. Customers are management. But the advantage of having PGs is that you can relax also. Now I think you will understand. And getting PGs here in this college and getting all these things done is a very big job. Congratulations, madam. Thank you very much. So since this is the first place I came here as a professor and HOD, I have a fond memories, and very great part of my heart goes with the GMKMCH. So any day, any help, you just call me, I'll come. And I am stunned to see this place is doing so much of good work, including cochlear implant. You know, most of the ENT surgeon in Salem would not have done cochlear implant. That's because the doing a cochlear implant is not an easy job. More than everything else, when you start doing a cochlear implant, all the obstacles got to be overcome. You got to send the patient or send the patient's detail to Chennai, get the approval, and post again here. So nowadays, all the peripheral colleges like Salem, Dharmaburi, and Velur, every college has started doing cochlear implant, for which they have the best performance. So I congratulate everyone. I don't want to prolong whatever I want to talk. I am going to talk the whole day today. So thank you very much for giving me the opportunity. I congratulate the team once again. Best wishes for the conference.
Thank you, sir, for being here. It really means a lot for all of us. Now, it is my pleasure to call upon our respected Dean, sir, the captain of the ship, the heart-standing pillar of our institution, without whom this event would not have been materialized. I take great pride and joy in welcoming you to deliver the presidential address, sir. Please, sir.
Respected retired professors who come all the way to honor the occasion. Respected guest of honor, Dr. Anthony Irudiraj, sir. Respected medical superintendent, my friend, Dr. Danpa, as principal, Dr. Tenmori, faculties of ENT, and Vice Secretary and Treasurer of AOI Salem. A very good morning to all. On the outset, I appreciate the initiative taken by the department headed by Dr. Krishna Sundari for having come up with this idea of having a CME and as well as training the postgraduates in this technique, which has been seen only in the city colleges. I think such extension or sharing of knowledge from the privileged city colleges should happen to the peripheral colleges. Only then the shared knowledge can be brought to use to the general public. So that is the main focus of having this tertiary care hospital. So we work, we learn, and we disseminate whatever we have learned and trained. In that aspect, I appreciate the Department of ENT and also Anthony sir for having willingly spending time here and taking pleasure in training the postgraduates and the other assistant professors. I also in this instant appreciate the AOI secretaries and treasurers, Vice Secretary and Treasurer for having convened such a meeting so that we all get benefited. So thank you once again for coming here and gracing the occasion, sir, the senior retired professors and also a senior faculty of MMC. Thank you so much.
Thank you, sir, for your valuable address. We always look up to you. Now, it is time to honor all the respected dignitaries as a token of gratitude on behalf of the Department of ENT, GMKMCH and AOI Salem. Now, I kindly request our Professor Dr. HOD of ENT to honor our respected Dean, sir. Now, I also request our Professor Dr. Krishna Sundari Madam, HOD of ENT, to present the memento to our Professor Dr. Anthony, sir. Please, ma'am. Now, I request Dr. M. Kavita Ma'am, Associate Professor, Department of ENT, to present the memento to our respected MS sir. Now, I request Dr. Mahindran sir from Department of ENT to present the memento to our respected Vice Principal Madam.
I now request our HOD, Professor Dr. Krishna Sundari ma'am, to hand over a memento to the Department of Anesthesia, Professor Dr. Kailveli ma'am.
So I have to say that it's a pleasure inviting and thanking anesthesia department who are doing a wonderful job, and they have started a 40-bedded hybrid ICU in which there is a fullest facility as that of a private hospital, and the team is really working well, and I thank the team. Thank you.
Now, I request our respected Professor Dr. Anthony sir to honor all the respectable dignitaries of the Council of AOI Salem. Dr. Krishna Sundari Madam, President. Dr. Sabari Rajan sir, Secretary, AOI Salem Branch. Dr. Raj Tilak sir, Treasurer, AOI Salem. Dr. Shanti ma'am, Joint Secretary, AOI Salem. Thank you, sir. Now, I request our respected Dean, sir, to honor all the faculty members of the Department of ENT, GMKMCH. Dr. M. Kavita, ma'am, Associate Professor, Department of ENT. Dr. K. Mahindran, sir, Department of ENT. Dr. M. Praveen Kumar, sir, Assistant Professor, Department of ENT. Dr. S. Nadrajan, sir, Assistant Professor, Department of ENT. Thank you, sir. Now, I kindly request our respected MS, sir, to honor all the postgraduates of the Department of ENT, GMKMCH. Dr. Niveta, ma'am. Dr. Sasikumar, sir. Dr. Sanjay, sir. Dr. Rohini, ma'am. Dr. Uma Maheshwari, ma'am. Thank you, sir. Now, I request Associate Professor, Department of ENT, to honor all the staff nurses from the Department of ENT. Satyapriya. And Miss Devi.
On behalf of our theatre staff, Mrs. Pai and Uday Kumari, who are held up in the theatre to ready for the next cases, I request Satyapriya and Arun Devi staff to get their mentors.
Thank you, ma'am. We are immensely grateful for each and everybody over here for actively participating and making this live surgical workshop a great success. Now, I request Dr. M. Kavita, ma'am, Associate Professor, Department of ENT, GMKMCH, to deliver the vote of thanks. Please, ma'am.
Okay. So very good morning to all. It has been a great honor to be a part of this event. I thank our HOD madam, Dean sir, and all the administrators for giving this opportunity. On behalf of Department of ENT, I take this opportunity to thank our respected Dean sir. He's always been supportive to our initiatives and encouraged us in every stage of this preparation of this live surgical workshop. Thank you, sir. We register our special thanks to our medical superintendent, sir, as well as observer of this live surgical workshop, our medical superintendent, and for his great support and guidance rendered by him. I also wish to extend our sincere thanks to the Vice Principal, ma'am, to gracing the occasion. Thank you, ma'am. On behalf of our department, I would like to acknowledge our gratitude to Professor Dr. Anthony Irudhirajan, sir, Professor of EIORL, RGGH, Chennai, who accepted our invitation in spite of his hectic schedule and conducted this live surgical workshop in a successful manner and share his knowledge with us. Thank you, sir. And I also express my heartfelt thanks to our HOD Anesthesia madam and Chief madam, and the entire team of anesthesia for their wonderful work and supporting us for this live surgical workshop. A special mention to our department of OG who spared the conference hall for this occasion. Thank you, madam. And also I extend my thanks to our staff nurse, matrons and OT technicians and anesthesia technicians and FNAs, MNAs, sanitary workers and crystal supervisor who had helped us to conduct the program in a smooth manner. We also thank our PWD electrical and civil department for made the infrastructure ready for the conduct of these program in time. And also thank the representatives from the Smith & Nephew, Microlabs, Medifocus, Sun Pharma, and Philips Respiron Division for extending the support. I thank all the delegates and the senior professors from Salem for attending this workshop and made this as a grand and successful one. Finally, I want to thank, it's my duty to thank my department, assistant professors, postgraduates, CRRI, ward managers, who helped us in making all arrangements and made everything possible. Finally, இன்னொரு வேர்ட் சொல்லணும். எங்க ஹெச்ஓடி மேம் இங்க இல்லைன்னா அந்த ப்ரோக்ராமே ரன் பண்ணியிருக்க முடியாது. இஸ் a great organizer. You have to learn a lot from her. Thank you, ma'am. Thank you, one and all.
Thank you, ma'am. The inauguration session is over. Now the live surgical workshop will commence. Thank you, everybody.
In 10 minutes, we'll be starting our live surgical workshop. I request everyone to be inside the hall. Mr. Deepan Chakravarti from Philips Respironics is about to give us an introduction about the polysomnography and its interpretation.
We welcome Mr. Deepan Chakravarti from Philip Electronics to present his seminar.
Good morning, doctors. So today we are going to see about the polysomnography report interpretation. So first thing is I'll just go through the common report parameters, what you see in use and what interpretation from that. If you look at the polysomnography, these are the electrodes.
So these are the places where you will be fixing up the electrodes. In the face and the scalp, you'll be seeing electroencephalography, oculography, and chin EMG. Next is ECG and thoracic and abdominal sensors and body position sensor to monitor the patient's body position. Next is the leg EMG one and pulse oximeter. So how do we differentiate the levels of polysomnography? There are various devices, levels of devices in the market. There are few devices which only monitors the respiratory flow, oxygen saturation, and body position. These are called screening devices. And along with that, if you're monitoring position, snoring, EMG, and ECG, it becomes a polygraphy device. And if you're adding some sleep, sorry for the disturbance. And if you're adding some sleep parameters like EEG, EMG, and EOG, it becomes a complete polysomnography. The word itself says poly means multiple, somnol sleep, and graphy is graphical recording of the entire body. So we have level 4, that is a basic screening device, that is RU sleeping device. Next is level 3. It's a much more than a screening device with respiratory saturation added to that. Then we have a level 2 home-based sleep test portal where you can carry the sleep lab to the patient bedside or to the home also. So it includes neuro channels, respiratory channels, muscular channels, cardiac channels, therapy device channel, and miscellaneous channels. So we have a Alice PDX device for that. Next is Alice level 1 device, which is an in-lab polysomnography where a whole night one attended sleep technician will be monitoring the patient throughout the night. So this also includes a video and audio recording throughout the night. So if you put this in a graph, this becomes in-lab testing, and the second one becomes the out-of-center testing, and this is screening device. So as per the ASM guidelines, there are some recommended parameters to be included. That should be included in the sleep parameters. Those are EEG derivations, EOG derivations, chin EMG, airflow sensors, respiratory effort transducers, oximeters, body position sensor, and other sensors such as esophageal pH and ETCO2. The report also does consider some sleep scoring data, which is lights out and lights on time, which is once the study started and when it is ended. And total recording time, the time between this lights on and lights out time, and total sleep time, how much time the patient is sleeping in the bed. It also different stages of sleep, that is stage N1, N2, N3, and R. And it also represents sleep efficiency, how good the patient has slept throughout the night. So total recording time minus the total sleep time into 100. So you can see this is a sleep architecture which the report sees. So first patient is in awake stage, then goes to stage N1, N2, and then for N3, then reaches to REM stage. This complete cycle takes around 60 to 90 minutes for one sleep cycle. Like this, every individual will be going through several sleep cycles throughout the night. The first half of the night, if you see, it is predominantly of NREM stage, and second half is predominantly of REM stage. These dark ones are the REM stage. Again, the sleep data, sleep report should also consider the sleep latency, how easily the patient went into sleep, what is the time taken for them to reach the sleep, and stage R latency, that is how much time they have taken to sleep. And it also should include VASO, which is wake up sleep onset, which means once the patient has gone to sleep, how much time they have felt awake after sleep onset, which means, for example, old age patients will be awake after the half of the night. So these and all should be calculated and reported in the report. Next is these are this normal sleep architecture. Normal sleep architecture efficiency is around 80 to 85% in a normal individual, and such 20%. Depends upon the age. So these are different different age groups with normal values, which shows normal arousal and arousal index, and staging wise classification as per the gauge group from 18 to 70. Excuse me. So again, the report consists it's a sample report which says at what time the study started, which is lights out time, and when was it ended, it is around 5:50 a.m. And in between these is the total recording time. We also have total sleep time in this and how much patient has slept, that is sleep efficiency, 93.2%. Above 85% is considered to be normal. Next, we also have number of awakenings after sleep onset. So this will get counted on the VASOF. And next, we also have how many periods of REM and what is the REM latency time taken. Good report should also give you a visualized pie chart of the stages, which shows how much stage of N1, N2, N3, and stage R, and how much they have spent in wake stage also. And then, if at all required, it can be a pie chart also for easy understanding of the clinicians to see the patient condition. Next is observation of cardiac events, arousal events, movement events, and respiratory events. So in cardiac events, generally we will be interested to monitor about the mean heart rate and the highest heart rate during the sleep. If it is any bradycardia present or asystole and tachycardia is present. Next is the arousal index. So this one will differentiate how many count of arousal throughout the night, and in that non-REM stage how many arousal had and REM stage how much it had, and it also differentiates between the respiratory related arousals, spontaneous arousals, and leg movement related arousals. Then this arousal index also will correlate with the periodic limb movement index, and these are the normal values which says PLM index and the PLM arousal index. So PLM index normal value is if it is above 15 in adults, and for children if you have bruxism more than 2 events, these are to be reported in the report parameters. And REM behavioral disorders, if it is seen, that also need to be noted. If RLS is there in wake events that do not meet limb movement scoring criteria, and key is the history and observation, we have to correlate with the raw data and evidence. So in reports you will get all in short forms. A means apnea, this is number of apneas. OA represents obstructive apneas and mixed apneas as MA. Central events, central apneas, hypoapneas, obstructive events, mixed apneas, central hypoapneas, apneas and hypoapneas. How these are calculated? These index are number of obstructive events, mixed events, central events into 60 divided by total sleep time. It largely varies. If your recording time is higher, then these events may get reduced from the calculation. So we need to promptly understand the total sleep time. And obstructive events, mixed events index, central apnea index, hypopnea index, obstructive hypopnea index, mixed hypopnea, and central hypopnea. And apnea hypopnea index. This is the value we'll be seeing in the, includes all the apneas counted into 60 divided by total sleep time. Right. And this report also should include a respiratory disturbance index, which is a count of RERA plus AHI into 60 divided by total sleep time. Next is the respiratory events. Number of oxygen desaturations, which is lesser than the baseline, that might be more than 3%, lesser than 3% or 4%, and OD saturation index, mean arterial saturation, minimum arterial saturation during sleep, presence of hypoventilation if it is present in the patient. Mainly, even if it is in adults, it may be present, but for children, it is highly recommended to put hypoventilation. Adults, optional, reported. So these are the values of disturbance. You can see adult for AHI up to 5 is normal, and 5 to 15 becomes mild, 15 to 30 is moderate, and above 30 is severe. And for pediatric patient, the parameters varies. For AHI, if it is more than 1, it has to be normal, and 1 to 5 is mild, 5 to 10 is moderate, and AHI of more than 10 is severe for children. Here the scoring, whenever they miss one breath, 2 consecutive breaths, it becomes one incident of obstructive apnea. This is a sample report. This is an oxygen saturation table which shows what is the percentage of saturation in each stage compared to the time spent in the total sleep time. So ASM recommends the report parameter should consider all the sleep diagnosis, EEG abnormalities, ECG abnormalities, abnormal behavior if it is noted during the sleep study, and the technologist summary and notes, and a histogram. Technologist comment is also a key. If at all he finds something, the physical and the emotional status of the patient, and describe some audible breathing and snoring sounds. Atypical findings which are not evident in the routine tabulation of the sleep stages and events, such as alpha sleep medication related EEGs, atypical motor activity during REM, parasomnal like activity, or any other pertinent perceptions. Last, the report should have a hypnogram which shows a pictorial representation of the entire night events, which will be easier to understand for the clinicians between the body position related with abnormal events, apnea, hypopnea, and saturation with limb movements and arousals. So this is a typical histogram which shows the body stages of sleep along with the saturation with heart rate, wherever there is increased heart rate along with arousals and respiratory events can be visibly seen and correlated with the body position. So it should also, the summary should also have a dictated summary which has the for the study, description of monitoring the parameters and recording montage, a description of sleep architecture, respiratory events and oxygen saturation levels, periodic limb movements and arousals, and cardiac events if present, any other EEG abnormalities, and it should also have impression, diagnosis with ICSD coding, and comments if applicable. It also should have a recommendation what the medication has been prescribed, whether PAP or surgery, modality of pressure, titration study, follow-up, precautionary statements, the process, and the review of the patient and compliance. The review of the patient history and complaint, review the comments and technology notes, review the hypnogram, view the raw data, look at what the patient presented and what you got on the raw data are similar, and there also can be scoring checks. So we need to do a manual also if needed. Data tabulation could have occurred when the reports are developed. So the take-home messages have a friendly report tool which makes under the patient condition easier and understandable. Use equipments and software should be updated, and multiple report types are there, diagnostic, titration, split night protocols. Thank you. So we do have a sleep lab displayed outside. If you have any doubts, we can just clarify there.
The next procedure is to start shortly. For your patients.
So good afternoon, everyone. Thank you so much for the opportunity once again. I need to show something new with third generation of coblation. So coblation technology is only available from Smith & Nephew. Like just because things look the same from the outside doesn't mean they are the same. So I'm happy to announce a new product, Coblation version 3, generation 3. So the Werewolf, one device, one system, multiple procedures. So this is a van with come with dual electrode system, less clogging, dual coagulation and consistency and more precision. So the answer is no blockage while doing the procedure. It can be 90 degree, you will not get any kink in the van. So this is our new generation of coblation, and we have the display over there in the OT. So probably, if possible, Antony sir will explain the remaining things in the session. Thank you.
Thank you, sir.
Hello.
ஹலோ, கேக்குதா? பேசலாமா? அங்க யாராவது இருக்காங்களா ஆடிட்டர்? Hello, we are calling from theatre. Natarajan sir? Hello, Natarajan sir?
Hello, yes, ma'am.
Sir, can you hear us, sir?
Madam. Yes, sir. Yes, ma'am.
Yeah, we're coming into the theatre,
Video
sir. Wait
வரல,
a
madam.
minute, sir.
Theater video. Okay.
இப்போ theatre எங்கப்பா வீடியோ இருக்கு? எது கவர் பண்ணி இதையா? இது, ஓகே. Okay. So now we'll go on with the second section, sir. The patient name is Kanaga, 37 years, female. She underwent total thyroidectomy in 2018 and tracheostomy was done on 22. And her thyroid profiles are within normal limits and she is on Etroxin of 100 micrograms. And we are planning for the modified Kashimas.
We welcome the moderators for this session, Dr. Premnath sir and Dr. Lakshmi Narayanan sir. Please, sir.
Hello, sir. Sir, can you hear us, sir?
Yes, ma'am.
Nice, sir.
Yes, we can hear, madam.
So we're happy to have Lakshmi Narayan sir and Premnath sir as the moderator for this session, sir. We are planning for the modified Kashimas coagulation assisted posterior cordotomy, sir. You can have some discussions. The patient is being prepared now. We're going to give the anesthesia through the tracheostomy done. And we are going to use the Storz laryngoscope with the coabulator MLW vans. அது band உள்ள இருக்கு. இது நியூ மிஷின் பத்தி சொல்லிட்டீங்களா? So this is the MLW van, sir. It costs around 31. The cost is around 31,000 with the tax. And I think I can hand over to Professor. You can clarify your doubts or you can have your queries before we start our case.
Hello.
Anthony, sir. Yes, sir.
Hello.
Yes, sir. Yeah, we hear you, sir.
I'm Dr. Prem. Dr. Prem. How many cases can we use this wand for?
How many cases we can? 3 to 4 cases, it seems, sir. MLW wand.
Oh, right. Okay.
I think they demonstrated the new machine of Smith and Nephew, sir, coablation.
Okay.
It's called Werewolf, sir. ENT. That's a coablation of the advanced machine, which I think they'll be focusing. What's the advantage?
Yes.
You can speak. Where is the mic? I think Joseph will explain a bit about the new coablation machine. For picture, you speak. Handing over to Joseph from Smith and Nephew, and he'll be speaking few words about the new coablation machine. What's the cost? Appa solunga. Now only we have brought it into the. This new coablation machine is brought into the market now only, and the price has not yet been fixed. But he'll be speaking about the advantages of this new coablation. Joseph,
good afternoon, everyone. I am Moisen Joseph from Smith and Nephew. Old generation coabulated 2க்கும் werewolf-க்கும் differentiate என்னன்னா இதுல LED integrated LEDs இன்பில்ட்டா இருக்கு அண்ட் பிளஸ் வந்து பாத்தீங்கன்னா இன்டிகிரேட்டட் இரிகேஷன் சிஸ்டம் இருக்கு. ஸோ கோபுலேட்டர்ல பாத்தீங்கன்னா கண்ட்ரோல் இரிகேஷன் செப்பரேட்டா இருக்கும், இதுல இன்டிகிரேட்டட் இரிகேஷன் சிஸ்டம். ஸோ ஃபுல்லா
Okay. Okay. He's saying that usually irrigation will be separately connected there. In this mission, it is all integrated. And is Ratnakumar sir available there from Smith and Nephew?
Is available? Irukara?
And also that will let us
Yes, ma'am. Good afternoon,
discuss.
ma'am.
Ratnakumar, can you explain about the Werewolf ENT new coagulation machine?
Yes, ma'am.
Its advantages?
Yes, ma'am. Sure, ma'am. Yes, ma'am. This is our new generation of population, third generation.
Ratnakumar,
So it has
excuse me, Ratnakumar, let us-
integrated pump system, ma'am.
Ratnakumar? Okay, fine. Ratnakumar, sorry for interfering.
Yes, ma'am.
We'll
Can you
go
hear
on
me,
to
ma'am?
Yeah, we'll go on to the external video. Sir is starting the case. We'll continue yours a bit later.
Okay. Thank
Sorry
you,
for
ma'am.
that. Thank you. External camera அங்க. Sir, உங்களுக்கு கேமரா வச்சிரலாம்ல சார்? Praveen? Sir, the camera வச்சிரலாமா? External? Focus ஆதாப்பா?
Hello? People in the theater, can you hear me?
Yes.
Can you get? Are you getting
Yeah,
the
we
end
are
of
able to
picture?
hear you.
Sir, are you getting the end of picture, sir?
No, end of picture we have not yet got. No. No, only the outer picture.
Premnath sir?
Yeah, we are getting
Hello.
the external picture, but not the
Sir,
end.
if you they are trying it, sir. If you get the internal picture, please inform us, sir.
Yeah, sure.
இது என்னாச்சு?
Yeah, now we have got the end of picture.
No. Don't do that. வேணாம் அது வைக்காதீங்க. அதிலே பாரு. வந்துட்டேன் அது ஏன் மாத்தாங்க? Hold this. Stuff இது போட்டுலாம் double towel போட்டு body towel போட்டு. வந்துட்டால இது படம் ஏன் ஆச்சு என்னாச்சு? ஏன் எடுத்தாங்க அது? நீ பார்த்தீங்களா ஓவரில் இருந்தது. எனக்கு பார்ப்பாங்களா அவரு பார்ப்பாங்களா? நான் பார்க்குற இடத்துலேருந்து பார்க்கணும் அவர், அப்போ தான் தெரியாது.
Natarajan sir. Hello, Natarajan sir.
Yes. Yes, ma'am.
Sir, we are starting with the case.
ma'am.
I think your endo picture is available for you, sir. Is the endo picture available for you there, sir?
Yes, ma'am.
Okay, sir. Now we are starting the case, sir.
Yes, ma'am.
It is available.
Yes, ma'am.
Like this, like this. So, yeah. Yes, sir. Doors on. Here, focus on follower, sir.
Good afternoon, everyone. Hello.
Yes, yes, please continue, sir. Good afternoon.
Good afternoon, sir. Can you hear me?
Yes, we can hear you.
So, in the picture,
External camera வேணுமா சார் இப்போ உங்களுக்கு? சார் external camera.
So, first we introduce the scope. The position is a neutral position, like how the anesthetic is put into the tube.
Zoom here.
Okay, once you have put
இதுலயே
that
போடுமா? இதுலயே போடு.
இது
கனெக்ட் பண்ணிட்டு
chest piece.
செஸ்ட் பீஸ் எடுமா. சாஃபி செஸ்ட் பீஸ் அந்த கனெக்டர் எடுங்க. செஸ்ட் பீஸ் அண்ட் கனெக்டர். அது
ஏன் கழட்டி வைக்கிறீங்க?
கழட்ட கூடாது கேட்க மாட்டாங்க. நான் சொல்லிட்டேன் கழட்டாம தான் வைக்கணும்னு. மெதுவா மெதுவா ஸ்டெஃபி.
Hold this. Chinmo. கீழே. இன்னும் கொஞ்சம் கீழே you hold. தான் கீழே. Hold. இன்னும் கீழே. எதையும் க்ளோஸ் பண்ணக்கூடாது. வேணாம் விட்டுறேன். எது மூவ் ஆனாலும் தெரியாது. Do you get a picture now?
Yes, now we have got the end of picture.
Hold this. உன்னோட வேலை இது இப்படி நேராக இருக்குதான்னு பார்க்கணும், இது இப்படி ஹரிசாண்டலாக இருக்கான்னு பார்க்கணும். ஓகேவா? செக்ஷன் இது மட்டும்தான் உங்களுடைய வேலை. அசஸ் அவங்க பண்ணுவாங்க.
Excuse me, when was the tracheostomy done? When was the thyroidectomy done?
So 3 years after the total. So 3 years after the total thyroidectomy, sir. Tracheostomy is done after 3 years.
Oh, she developed the abductor palsy 3 years later?
Actually, she came to us by 3rd year, sir. She landed up in the OP by third year.
Okay, okay. Maybe it was a mild stridor.
Okay, so usually for the first 6 months, there's a possibility of. Hello, can you hear me?
Yeah, yes. We are able to hear you.
For the first 3 years, I mean, first 6 months of your bilateral abductor palsy, there is every possibility that the disease can recover. So you don't do any radical procedures in these 3 destructive procedures in these 6 months. Okay. If it's not, patient is not recovered after 6 months, you can do a procedure like posterior chorotomy, arytenoidectomy, and things like that. But
yes.
But the okay, but இதை மட்டும் பார்த்துக்கோ நீ, இதை மட்டும் பார்த்துக்கோ. Okay, so before that, if you want to do a lateralization procedure, you want to give an airway, then it's always advisable to do a temporary procedure like a suture lateralization. Okay.
Yes, sir.
So suture lateralization is the best procedure to do for the first 6 months. If you are after 6 months with your ENOG report says there is no possibility of improvement, then then you can do the destructive procedures like this. Okay. So when you do when you as for the youngsters, for the juniors, when you start doing, when you have a vocal cord paralysis, there are 3 things which are important in a non-functioning vocal cords. One is aspiration, second one is voice quality, third one is airway. Okay, when the patient has got aspiration, patient will have a poor voice quality, but the patient will have a better airway. But when the
Okay.
patient's voice quality is bad, when the patient's voice quality is when the patient's voice quality is bad,
Yeah.
patient will have a better airway. When the voice quality is good, patient will have a poor airway. But
Yeah.
that patient
Yes.
will not have aspiration. Okay. So this is the vocal
Yes.
cord. The vocal cord has got anterior 2/3 and posterior 1/3. This 1/3 is
Okay.
cartilage. Okay.
Yes.
So this is the posterior part of the cord. Okay. So
Okay.
the idea of this surgery is that you make a window from here, this is the false vocal cord, to the true vocal cord. Okay, you make a
Okay.
window, continuous window like this, then
Yes.
patient will have a air, when the patient breathes inside, there will be a negative pressure and the air can be sucked inside. The idea of the surgery, the result is you give a adequate airway, serviceable voice, but you should not
Yes.
injure this area so that the patient will not get the aspiration. Okay.
Okay.
If at all you
Yes.
want to do something better than the posterior cordotomy, you can do a medial arytenoidectomy. Okay, you can remove
Okay.
the vocal process as well as the medial wall of the arytenoid. Okay,
Okay.
but that will give you the better results.
Okay.
எங்கப்பா ஃபுட் பிளேட் எங்க வச்சிருக்க இந்த சைடு எடுத்துருவா இங்க வேணும் இங்க வேணும் okay so this
Yes.
is the microlaryngeal band. Okay, you have a
Yes,
LW band, it's called a laryngeal band. Laryngeal band is useful for the bulk surgeries, like you want to rebore, you want to remove the benign tumors, LW band is better. But for a microlaryngeal, for example, you want to remove the vocal polyp, you want a sharp dissection, you need a MLW band. This is a microlaryngeal band, otherwise called MLW band. I'm going to start the case. Okay.
Yes. Yes.
You can see the vocal cord is getting cut.
Yeah. Yes.
Okay. But generally the people do only cut the true vocal cord. They don't cut the false vocal cord. But you should cut the
Okay.
false vocal cord also to get the good results. So that's a false
Yes.
vocal cord. I am cutting the false vocal cord, making a window. Okay. Then
Okay.
I am going to cut the true vocal cord.
Okay.
Usually it's not advisable to do this case without a tracheostomy. You can see once
Yes.
you have cut this, it's opening like a V. Can you see?
Yeah. Yes, sir. Yes.
That's a opening like a V. So this
Yeah,
part
yeah.
of the vocal cord is important for phonation. But the problem
Okay.
is this patient, you can have a mild, you can see the patient has got a mild grade 1 sulcus vocalis. But
Okay.
so you keep cutting this.
Okay.
So if you make the V, if you make the V,
Yes.
your airway will be good. Okay. So this is
Okay.
the posterior cordotomy. But I prefer cutting the false cord also. Okay. So this is
Okay.
the vocal process. This vocal process will decrease the. So what is your lateral level of removal? So lateral level of removal will be your inner perichondrium of the thyroid cartilage.
Okay.
Sometimes it might bleed. Okay, if the bleeding,
Okay.
it's very difficult to arrest the bleed with the MLS band. Okay, so
Okay.
if that is the
Okay.
case, what we do is if the focus is clear,
Yes, it's clear.
it's a maximum.
Uh, space, maximum space produced.
No, it's the maximum enlarged magnification I have given. So
Okay.
so now I am slowly going near the. See, there is something called muscular triangle. So this area is the muscular triangle. If you open
Okay.
here, you get the better
Yes.
airway, but it will start bleeding.
Okay.
Okay, it will start bleeding. So it's not advised.
Yes.
You can see the inner pericardium now. Can you see the pericardium, whitish one? Can you
Yeah,
see
yeah,
here?
we can appreciate. Yes, we
Inside,
can
that's the inner
appreciate.
pericardium. Okay,
Yes.
so you are. So this place it can bleed. If it bleed, we coagulate. But if it's not get, see, you can see the inner pericardium here. Okay.
Okay.
I want a cup forceps. Do you have a upturned cup? So I'm so stunned to see this place where you get such a fantastic instruments.
Yeah, yeah.
That's a anterior to that of the card. Okay, can you see this?
Okay.
So this is
Yes.
this should be here, but because you cut the cord has retracted anteriorly. So this
Okay.
cord is used for
Phonation.
phonation. While
Okay.
this is the airway what you get. Okay, if you are
Okay.
not happy, you
Okay.
can remove this cartilage which is jetting out. Okay, but I'm not going to
Okay.
do that because
Okay.
I could see the inner pericardium well. See, this is the false vocal cord which I have cut up to the lateral level. I have cut in between tissue. I have opened up the true vocal cord, and you can see the vocal cord going anteriorly. So the space is
Okay.
enough for the airway. I'll show you the exact
Okay.
space now. I take out the cotton. What is there inside? Oh my God.
Yeah, it is
Cotton
quite
ball,
wide now.
Cotton ball. Cup forceps or cotton ball. Wrong cotton ball, plain cotton ball. Nothing. This is to wash. This is to wash.
Sir, end of picture you are not getting. Ah, now we have got it.
You got your end picture?
Yeah, yeah, now we have got it.
See the inner pericardium?
Yeah,
See the
yeah,
airway?
yes,
See the inner
Okay,
pericardium?
yes.
So this is the anterior
Yes, we
part of
are
the
able
cord.
to.
You can see the vocal process. Can you see the vocal
Okay,
process?
yes.
This is the vocal process. Okay, you
Yeah,
can
yeah, we are
take
able
out
to.
the
We are
vocal
able to
process.
see.
If you take this part of the vocal process, which is jetting out like a triangle, which is not required.
Okay.
Unless you get a
Okay.
very small airway, this is not sufficient airway, then you can remove this also. Then it's called posterior cordotomy with a medial arytenoidectomy.
Okay,
Okay,
okay.
you remove all
Yes.
of this is called arytenoidectomy. This is your
Okay.
apex of the arytenoid. This is muscular process. This is vocal process.
Okay.
Okay, if you
Okay.
remove the vocal process, that's called medial arytenoidectomy. But if you remove this
Okay.
part, it will go for
Okay.
aspiration. Okay, so this is
Okay.
that's the end of the case. Okay,
Okay.
any doubts?
Yes.
Any doubts you want to
Sir,
ask?
which side shall one do? Left side or the right side?
Sir, actually speaking, which side is partly working, that side you should not do. Okay, for that you got to do a electromyography of the laryngeal muscles.
Okay.
For 2 years after that, you got to do an electrolaryngography of the muscles. All
Okay.
these things are all too much for us, particularly
Yeah,
for
yeah.
people who work in the government hospitals, as you know.
Yes, yes.
So if that is the case, you can see the dysphonia plica ventricularis. The ventricular bands are thickened here.
Yeah.
Okay.
Yes, yes, yes. Yeah.
So this is the posterior cordotomy. Okay, the idea is you should cut both the false vocal cord and the true vocal cord. Okay. You got to remove the false vocal cord and true vocal cord. Then, so this
Sir,
is
one
the
more
false
question, sir.
vocal cord. That's the true vocal cord.
One more question.
You can see the lamina. You see the where? Can you see there? You can see the vocal process. Yes. What's the question, please?
Sir, post-operatively, till when we should wait to give the decannulation trial? Is there any waiting period?
If I do in my hospital, I'll do it now. If I'm very sure that all other parts are all fine, I'll do it now. But
Okay.
For beginners.
best way to do is that depends. Okay, we have got another case to do a posterior cordotomy. I'll ask them to show that video to you. The patient's video laryngoscopy has showed patient has got a high and the low obstruction of the tongue base. Patient is little obese, and he underwent thyroidectomy, and his TSH level was very high, and now he is on. It was very high, and he's got a little hypothyroid. So those are the patients you don't opt. So it's unfortunate that patient has developed bilateral abductor palsy. So those patients you got to take it out carefully, because such a OSAS patient who underwent tracheostomy, which is the gold standard treatment for OSAS. So that patient you cannot decannulate it straight. He is almost like used to the tracheostomy breathing. So you got to decannulate slowly. What you do is you keep reducing the size of the tube, like how you decannulate in the children. But other cases, generally, you can take the patient to the ward, and then you can put a Shiley's tube or a double tube, like Fuller's biflant tracheostomy tube, and start decannulating it. If you can tolerate for 72 hours, you can suture it. Okay?
Thank you, sir.
So that is the wonderful trachea and subglottic area. Okay?
Hello, sir.
Yes?
Hello, Kavita, sir. It's a very good demonstration. Really visual trick for us, sir. How to prevent the aspiration?
You can't prevent aspiration.
Is there any possibility, sir, after the surgery is aspiration?
No, that's what. When you remove this part, okay, what you see now, when you remove this part, it will go for aspiration. So you can see here, you see a linear ulcers. You can see one or two ulcers, then pink mucosa, then streak of ulcer, pink mucosa, streak of ulcer. This is called zebra sign. Zebra sign is the characteristic feature of the reflex esophagitis. You got to treat the reflex esophagitis of this patient. If you don't treat it, then the reflex on the bare vocal process can produce little bit of granulation tissue, which will delay the decannulation. So you got to treat the reflex for this patient. This patient otherwise is not very obese to have a reflex. So when you treat the reflex, the decannulation will be better. Once you remove this part, then you got to make the patient swallow with a straw, and slowly you should have these swallowing techniques got to be done. For example, head thrust, or put the use one pyriform fossa to swallow, and you should learn the functional endoscopic swallowing techniques, C's. So you got to get these people to work on them to make them swallow. That's a tedious job. So see to that you don't remove this mucosa, then the patient will be doing fine. Okay.
Okay, sir. Thank you, sir.
Thank you.
Hello?
Yes.
So what is the difference between Kashima and modified Kashima?
Kashima is cutting the vocal cord alone. Modified Kashima is cutting along with the ventricular band.
Okay. Thank you, sir. What are the other ways, apart from this coablation, what other instrument can we use for posterior cordotomy? What other devices?
No, first thing is laser. Laser.
Okay.
We don't have laser. So we are doing it the coablator.
Is that the best, sir? Laser?
Yeah, laser is the best. You get a sharp cut. Here you have a little bit of tissue loss. No, there will not be any tissue loss. You cut 1 millimeter, it will be just 1 millimeter.
Okay. What other devices can you use? A cryoprobe?
Actually, in GMKMCH, we have used
radio frequency.
We have used we put a sheath for a sickle knife, and then we used diathermy, and we used
Got
the
it. Okay.
cold stream.
Okay.
Okay, but these are all the things which produces more of fibrosis, and particularly when
Okay.
you don't, very difficult to cut the ventricular band with these instruments. So the chances for
Okay.
success will be high. But this is only you can repeat the procedure. It's only a 10 minutes procedure, so that's not a problem. Okay.
Oh, okay. Thank you, sir.
Thank
Anthony,
you. Thank
sir.
you. Thank you. Yes.
Hello, sir. Is
Yeah,
there
I'm hearing.
any possibility of Sinake in the raw area what we are creating, sir? So
Yes.
already we opened.
Yes.
Already we opened very ample amount we opened, but it heals by granulation only. Is there any
No, it
possibility
will
of
not.
Sinake?
It will not heal by granulation. That exposed part of cartilage alone can get granulation. That too, when you don't treat the reflex properly. If you treat you saw how the reflex is going inside, but even that will not go past you can see on the opposite side, that will not go past the posterior part of the arytenoids. You don't come to the anterior part of the arytenoids near the vocal process. The healing is not by the granulation tissue. When you cut the ventricular band, actually, there's a tensor of the vocal cord, right? There are tensor, the internal tensor and the external tensor. This pull the vocal cord. So once the vocal cord is pulled, when you cut it, the horizontal cut will become a V. So unless it touches each other, the fibrosis will not come. Okay. So generally speaking, it's not come. But that's what. If this is the adequate airway to do a normal work. But our idea is not to give the normal airway. Our idea is to give us adequate airway. The adequate airway is to do the day-to-day activities only. Okay, it's not to do a strenuous exercise. You can't ask her to run a 100-meter dash or take a heavy object for 4 floors, 5 floors, lifting the object. What they can do is they can do a serviceable. You do a adequate airway, and similarly the voices she can't go and sing in the concerts. Understand, the voice will be only a serviceable voice. You talk, the patient can hear. But the thing, you talk, somebody can hear and understand. But they can't raise the voice, lower the voice, and give the commands or use a loud voice, or they can't sing. It's only a serviceable voice. That's an idea of doing this surgery. If the patient is not willing for serviceable voice, you can't do this, and you can't make you can't close the tracheostomy. You understand? So the idea is only an adequate airway. That adequate airway will be maintained when you cut this much amount.
Sir, I can able to understand to prevent that fusion, you went up to the false cord. So one that will give a ample amount of space. Then you are taken the inch of cartilage. Even the cartilage is not cartilage. You take that to give adequate space and maintenance of space without any complication.
Yeah, some people keep mitomycin C there to prevent the fibrosis formation. But I have been doing this for almost, I did my first case in 2010. So it's almost 12, 13 years. We have been doing everywhere. And of course, you can't give you any guarantee that you become all right. So if if the patient is getting a narrow voice, narrow airway, you cannot decannulate the patient. If you don't decannulate the patient, repost it. Do little more. Okay, the same thing is true for cord lateralization also. The same thing is true for, see, my chief used to tell, okay, when you do a when you do a hydrocele operation, there is only one surgery. If there is only one surgery, that means that surgery works very well. But you do a CA rectum, you do it for prolapsed rectum. There are about 35 surgeries for prolapsed rectum.
That means no surgery is good. All of us, our generation will know what are all the treatments for bilateral abdominal palsy. You do Kelly, Keith, Kelly, Orton, you get a Woodman surgery, and you have about 13, 14 surgeries. That means no surgery is good enough. So this surgery is a workable surgery of today. Tomorrow you might get a better surgery, or you do a re-innervation techniques might improve, or you get a implantable devices which makes the nerve work again. So all these things are all in future. Even the future you can do a laryngeal transplant. Okay, but it's all in the pipeline. But today, best accepted surgical procedure for vocal cord paralysis is the the posterior cordotomy. Is it clear?
Yes, sir. Thank you. Thank you so much.
Thank you, Anthony, sir. It was a wonderful demonstration. Thank you.
Thank you. Thank you. Thank you.
Thank you, sir. Now, I request Dr. Kavita ma'am, Associate Professor, Perundurai Medical College, to present the memento to our moderators, Dr. Premnath, sir. And I request Dr. Mahendran, sir, to present the memento to Dr. Lakshmi Narayanan, sir. Thank you, sir.
சார் ஆன் பண்ணுங்க சார். இல்ல சோர்ஸ் வெளியே போறேன்.
Thank you. We are now from the OT. The next case planned is Devi, 27 years, female. Complaints of snoring and mouth breathing for the past 1 year with a sore throat and referred autalgia. She doesn't have any apneic episodes, no history of previous surgeries, no comorbidity. Sleep study DICE was done for her already, and in sleep study AHI score was 47, and DICE was done for her. Velum collapse was there along with the epiglottis AP collapse. And actually, I request our professor to explain about the drug-induced sleep endoscopy. Over to sir.
Hello, can you hear me? Hello, can you hear me?
Yes, sir.
Yeah.
Yes, sir.
Fine. Yeah, fine. Drug-induced sleep endoscopy is, see, most of us have got a small confusions about OSA management. Okay. Obstructive sleep apnea is a disease which produces certain symptoms. The symptoms are, first, we do what is called a stop bank questioning or Epworth's sleep scale. This will give you an idea whether the patient is suffering from obstructive sleep apnea or not. If the patient is suffering from sleep apnea, you do a sleep study. Sleep study, even though you do lot of study patterns, generally that 24 channel sleep study is useful only for finding out the central causes and the peripheral, like your nystagmus and vertigo investigations. Most of these investigations are required to find out whether it's a obstructive sleep apnea or a central sleep apnea. For an obstructive sleep apnea, important things are all AHI and the oxygen saturation. So AHI will give you an idea whether the person requires treatment or not. The AHI up to 7, you can take it as normal. So 7 is mildly positive. So 7 to 15, 20 is moderately positive. More than 40 is severe sleep apnea. Okay. So once you see the patient with the sleep apnea, you got to check up whether the patient has got any metabolic causes for this disease. For example, whether the patient has got a hypothyroidism or patient has got any diabetes, hypertension, hyperlipidemia, all these conditions. If all these conditions are all there, you got to treat them, right? Then the gold standard treatment of sleep apnea is putting a patient on CPAP. The PAP is the most important, most vital treatment for the sleep apnea. So for this, the most of these neurologists and pulmonologists are butt inside, and then they started investigate the patient and tell you that yes, you have sleep apnea and wear a PAP. Okay, the PAP means you give pressure the air inside the oral inside the upper respiratory pathway. This pressured air pushes the tissue laterally and goes inside, right? Once the tissue density is higher, or tissue, when you push it, it goes on the opposite direction, the PAP doesn't work, or it will strain the patient. For example, if the patient has got a tongue-based collapse, you put a PAP, it will not lift the tongue base. So you produce more, you need a more level of obstruction. Okay, more level of obstruction. So the patient will not tolerate. Or if there's an epiglottis collapse, when the epiglottis collapses, you give more pressure, it collapses more. So air will not go inside. Patient will struggle and get up and then throw the PAP out. Or the patient who have a social problems. For example, he is embarrassed when he is traveling on a train. He makes a huge noise. So everybody will come and tell, what is this? You are snoring like this. Go and see a doctor. If the same patient goes and wears a PAP in the night, more people will come and ask him, what's your problem? Why are you having? What is this? Sir, I will the embarrassment for him will be more only. So if he doesn't want a PAP, okay, if it doesn't want a PAP, or if the problem is because there is a tongue-based obstruction or epiglottic obstruction, these pulmonologists or PAP sellers doesn't have a answer to that, because they don't see where the problem is. To find out where the problem is and to give an effective treatment, you got to do a what is called as DICE. To put a CPAP, is, unless the patient has got epiglottis collapse, the for a palatal obstruction or a tonsillar obstruction, that to give a PAP, the DICE will not be of much use. But for surgical treatment, it is the mandatory. So what do you do for a DICE? DICE is drug-induced sleep endoscopy. You put an endoscope inside the nose and see what are all the things happens when the patient's level of sleep is higher. So you induce sleep. Induce sleep in a theater, right? So what are all things you use to induce the sleep? We use midazolam. Midazolam is a drug which is very, very short acting and doesn't give you the good level of sleep variability. Second option is propofol. Propofol is a wonderful drug. You do with the propofol, make the patient under sleep, then you do it, you get excellent results. But it's all exaggerated results because propofol by itself will produce hypotonia. So because of it produces hypotonia, you give a propofol, you get the results, you get an exaggerated result. So you can push the patient for surgery. But the thing is, it's not an actual result. Okay. So then what do you do is called dexmedetomidine. Dexmedetomidine is a drug which gives you the but okay, fine. You give dexmedetomidine, few people snore, few people don't snore. How do you know whether this dexmedetomidine is work or not? For that you have a beautiful machine here in the department called BIS monitor, bispectral index monitor. The BIS monitor is a one which will give you the level of sleep. So you see the monitor, when the patient's sedation goes higher up and higher up, slowly the level of sleep will come down. That is, the till 80, patient will be sleeping, but the patient will not go into the plane so that patient develops snoring. You can see patient will come and tell you, sir, do you snore, me, sir? Yes, sir. Generally, I don't snore. That level of sleep goes to the level only, you get the more hypotonia and more snoring. Okay, so to get what is the ideal level to see is snoring. Ideal level to see is, those days we used to sedate the patient. Once the patient becomes too deep, then we'll slowly wait, because you can make the patient to that plane faster by giving the drug fast. But you can't bring the patient back. Patient will come out back only how the drug metabolizes. So we'll put the patient on a deeper, little deeper plane and wait for the patient to come out. Once the patient comes out, we'll see the what are all the obstructed areas are there. But now we have a BIS monitor. With the BIS monitor, when the BIS index is between 60 and 80, you get the ideal plane where the patient snores, and you can see the level of snoring. Okay, so what do you look for? You can pack the nose, or you can do it without packing the nose. If you pack the nose, you don't stimulate the respiratory passage. You can nicely go inside the nasopharynx. Doing the procedure will be easier. But the problem is, once you decongest the nose, the secretions will start coming in. So that will be very difficult for you to see the variability. Okay, so if you don't pack it, when putting inside, when you are not examined prior, you put the thing inside. If there's a deviated nasal septum, it can get injured and can produce trouble. Okay, so I pack the nose. So once I pack the nose, I go inside. I look at 4 important areas. One is the velum. So velum, before that you can see the you can see that tubal tonsil. So when you see inside, you have 2 things to look for. One is called the box and content theory. The box is the rigid wall. So the rigid wall can be nasal septal deviation, or there is a retrognathia, or the mandible is retracted. All these things are all bony walls. So there can be a small nasopharynx, there can be a small nasal cavity because of the retrognathia or the retromaxillary. The maxilla goes back. So these are all the wall, otherwise box. Then content is the more common thing where there's a soft tissue inside. So the septal deviation is also a gross septal deviation off on the you have a caudal dislocation with the deviated septum, so it's bilaterally obstructed, will also produce that you got to be corrected. Then you go inside, you see the adenoid. Then beyond that, you look inside the velum. Velum, you have an anterior posterior collapse. Anterior posterior collapse, or you can have a concentric collapse. Okay, so you have a concentric collapse. You can grade it 0, 1, 2, 3. Okay, then you go little below, you see the tonsillar area or oropharynx. Even if there is a tonsillar area, they can get collapse. It can collapse, will be a lateral collapse. Okay, that's at the tonsillar area. So oropharynx. Then you go inside what is called as am I audible? Are you following me?
Yes, sir. Yes, sir.
Yeah. So, yeah. Okay. Then what you... Hello?
Yes, sir.
So, next thing is you look inside the tongue base of tongue. So base of tongue, you can have a high tongue lesions or low tongue lesions. And the old tongue is hypertrophied, or because of retrognathia, you have a low tongue lesion. There's an high tongue lesion comes whenever there is a lingual tonsils. Lingual tonsil elevation can produce high tongue deviation. Okay, so these are all the various problems in the. Is it ready? So this is, we'll go start. So this is the introduction about the Ward's classification. So you can do a single level velum, tonsil. You can do it as a retropalatal. Similarly, tongue and the epiglottis is retroglottal. So that's called, there are two levels are there. You can do a single level surgery or do a multi-level surgery. If your backup system is very good, you have a beautiful post-op management area like PSCO, then you can do a multi-level surgery. Yeah, or otherwise you do single level surgery. Okay, you can do a single sitting or the multi-level surgeries can be done in single sitting or it can be done in multiple sittings. Okay, so if all these surgeries you have done a retropalatal surgeries, you have done a retroglottal surgeries, retroglossal surgeries, in spite of that you don't get a good results, then you do a maxillomandibular advancement surgeries, which are all the facial skeletal surgeries. These are all, this background we'll go and see how do you do a DICE here. Okay. This எங்க இருக்கு பிஸ் பிஸ்ல இது வருமே இஎம்ஜி வருமே இஜி மட்டும் தானா சரி ஓகே எனக்கு கொஞ்சம் கொஞ்சமா கொடுங்க டெக்ஸ்ட் போட்டீங்களா டெக்ஸ்ட் போட்டீங்களா கொஞ்சம் கொஞ்சமா கொடுங்க
So in the இது monitor, normal multiparameter, that is module and sensor, அது மட்டும் அவங்க சொல்லுங்க.
Can you see here?
Camera zoom in. In the monitor.
So this is the BIS monitor. Okay, this is your bispectral index number. Okay, so the patient is little sedated. It's about 95, 96 and things like that. Okay, so our idea of doing DICE is between 60 and 80. If it goes below 60 only, it will be workable. If it goes, below 80 only, it will be workable. You get the good results in the when it is about 60. This play also can be modulated if you do a EMG level here. If you see that hypotonia, if the level of 80 itself, some patients will go for hypotonia. Those are all the patients you can get the results at 90 at the 80 itself. If there's no enough hypotonia, even if it goes up to the 60 level, then we can wait. And second important thing is something called a LSAT. That is low oxygen saturation while sleeping. So when the low oxygen, some people will have, not these people, some people will have a lowest oxygen saturation even when the patient has got a, this thing is at, say, low saturation will be 65. So those are all the patients we don't get panic if there's the patient is desaturating up to 70 or 75, because we know even in the sleep patient is going for low saturation. And then other important thing is you should know that you should do a jaw thrust. The patient is sleeping. When the patient is desaturating, if the drug is more, you give a jaw thrust, and then you give you don't oxygenate the patient, because when you oxygenate the patient, that dry will go. So patient snoring dry will get altered. So if you once you finish the dice, or you don't want to continue the dice, then you oxygenate the patient. When you oxygenate, do a jaw thrust and then oxygenate, patient will do better. Okay, right? So this is the BIS number. BIS is the, see what I have found out is BIS is the most important parameter to be watched when you are doing a dice. Okay, without BIS, your results may not be reliable. If you have a BIS, if you are presenting a paper in an international journal of dice without BIS monitor, they don't accept, because they will tell you at what level you said you are measuring. We don't know. Okay, so that's another important thing to be noted in this.
Good morning, sir.
Good, yes.
Sir, good morning, sir. Sir, where
yes,
will you keep the probe? So where will you keep the probe?
Probe, yeah, this is the probe. It's the probe is kept in the forehead. It's like a small strip, disposable slip. Can you see here?
Yes, yes.
So this is the probe. This is connected. This is the module. So this is the BIS probe. Okay.
Okay,
This is
sir.
the BIS probe.
Okay, sir. Okay.
Okay, this probe
So
is, this is
we
the
can see.
module. This is the module.
Can we connect to any parameter, any multi-parameter?
No. This is multi-parameter, but they will give you a, see, this is not the ideal way of doing it, because here you don't see the DMG. But the thing is, you can see the number better with this. There will be a very small monitor, and somebody should stand next to that and watch what's happening. But that's ideal to do our procedure when you are doing here inside the theater. But to show, no, if the this number is coming down or saturation is coming down, you can't see it with a small monitor. That's why we are attached it to the multi-parameter. It can be attached to the multi-parameter which has got a channel in, but not with all the multi-parameters.
Okay,
Right?
sir.
Okay. You start, man. Thank you, madam. You give me a glove. ஒரு மாசம் ஆச்சு இது பண்ணி, இது எப்படின்னு தெரியல. ஒரு மாசம் ஆச்சு இது பண்ணி, இது எப்படி இருக்குன்னு தெரியல. லைட் சோர்ஸ் கேமரா. இங்கே ரைட். The theater workers here and the staff nurses are all so efficient that before we think of something, I want this, they are providing me. And there is something called the commentator's curse. This happens when you are watching cricket. You tell me that's a wonderful shot, he is in the very good form, he'll get out. Okay, so I hope this is not happening here. I could see the confidence of madam telling it will never happen. Most of the people who work with me knows. Saline மட்டும் தான். Saline இது வைக்க கூடாது. இது உறிஞ்சிரும். To clean the tip, don't use Savlon. Okay, because the Savlon on this one, on the on the scope will make the sheath damage. It's preferable to.
Hi, sir. Anto, sir. Can you identify me?
Sorry?
This is DC Saravanan, sir.
Hey, DC. Nice to see you, man.
Hello, sir. Nice, very nice.
இல்ல உனக்கு சொல்ல வேண்டிய அவசியம் இல்லை. You know how to manage the scopes. You clean the tip of an endoscope with the Savlon. You know it will cause Savlon will cause damage to the scope. Okay.
It will damage
So
the sleeves.
sleeves, yeah. If you want to do it, we can use the deviated septum இதாக வெச்சு deviated septum இருக்கா giving. So as it goes, you can see the slowly the bis is coming down. You can see that 50 mics the madam will give for sleeping. Sometimes she will tell, no, I have given that enough dose. But what I was worried about is that bis index. That's one reason why I use bis. Okay, you can tell them. See, other thing you should watch is you can watch the sound of the monitor.
Please.
Can you see the?
Please switch over
can
to
you hear
monitor.
the sound of the monitor?
No, sir, we are not getting endo picture.
Hey, Vinod, sonna une podu Vinod.
Endo picture, sir, endo picture not coming.
Yeah.
Karthi, they are making it ready, Karthi, just few minutes.
Okay.
Do you get now?
No, sir. No.
Yeah. Wait, one minute. That's a zeta case. See, this is the typical concentric
60
contraction.
to 80.
See? ஏ கொஞ்ச நேரத்துல முடிஞ்சிருடா டைஸே.
Yeah. Just wait, they are working on it. So at least tell them to show the monitor with the external camera.
Take it out in the hand.
கையில எடுக்க சொல்றேன். கையில கழட்டி அவங்க சார் பின்னாடி போய் நின்னு. It's coming. Karthi, do you get the endo camera vision?
No, madam.
பாங்க பண்ண சொல்லுங்க.
Hey, நீ கழட்டு மேன். கையில இந்த சைடு வா, அதை காட்டு. நேரா வந்து காட்டு. பேட்டரி இல்லையா? இங்க பாரு. இதுக்கு பின்னால வா. கழட்டு, பேட்டரி இல்லையா உனக்கு? எதிர்வா.
Sir, what drug they have given? Sir? கேட்கல.
Can you see now? Karthi? Karthi?
Karthi? Karthi, can you hear us? Karthi? Hello? Hello? ஆடியோ அங்க போல தம்பி.
Hello, sir.
Can you see here? ரெண்டு படத்தையும் போட சொல்லுவானே.
Hello.
சொல்லு கார்த்தி.
Sir, can you hear me? Sir, can you hear me?
Can you see now?
Yeah, we are
I'm
getting
hearing
the
you.
endo
Tell
picture.
me. Yeah, right, fine.
We are getting the endo picture.
Yeah, so this is the nasopharynx. Okay.
Sir,
This is
what
the
drug
velum
they have
level.
given, sir? Sir,
Dexmedetomidine.
what drug they have given? Dexmedetomidine. How much?
Dexmedetomidine.
The dose,
I'll tell
how
you.
much they
No,
have given?
wait. We can talk that without dice. Okay.
Okay.
So this is a patient who developed. So this now the patient this index is 81. Okay. Show this. The got tambi. Hey, the got.
Monitor coming.
You can see the BIS index is 82 now. Okay.
Yes.
So now patient started getting the snoring. You can see the velum. Velum level, you see the concentric contracture. Can you see the concentric contracture?
Yes, sir.
It's a round. It's anteroposterior as well as lateral. Okay. See, the uvula is coming upwards. Okay. So then you slowly go inside. When you go inside, so that is the below velum is the level of tonsils. Okay. In the level of tonsils, you get the lateral collapse. So to go below, see, this is the tongue. Okay, and that's an epiglottis. Okay, so the epiglottis can get collapsed laterally, or it can get collapsed posteriorly. If it's a very flaccid epiglottis, the epiglottis will buckle inside. Okay, so here the maximum trouble occurs at the level of the velum. Okay. So velum, there is a concentric collapse. So this is an ideal case to do a zetaplasty. Zetaplasty is like a SMR. It's a destructive surgery. It's a uvula destructive procedure. But still, we love to do SMR rather than septoplasty. You can see now you can see this monitor. So patient is snoring. The BIS index is 66. Okay, can you see? Can you see?
Okay.
So BIS is when the BIS is between 60 and
67.
80,
Yes, sir.
60 and 70, you get the snoring. I don't know whether you are hearing. We are hearing the snoring sound. Okay, and there is a concentric collapse here.
Yes, we are hearing.
Then, most important thing is the tongue-based collapses only at the level of 60. Otherwise, it will not get collapsed. So I don't see the epiglottis is not moving backwards. Okay, so there is no tongue-based collapse, not much of a tongue-based collapse. There's a little bit of okay. So this is the So the velum and the
Only the velum.
tonsil, oropharynx. That's the big problems. There is no problem at the level of the epiglottis or at the level of the tongue. Okay. So this is
Okay,
the
sir.
tongue. Can you
Okay.
see the tongue?
Yes, sir.
There's such a long uvula that when the uvula goes back, your tongue is getting upset. You still have a lingual tonsils here, but that's not giving you the max. That's a lingual tonsil. Can you see? That's not giving maximum double, and
Yes, sir.
epiglottis is
Only.
fine. Okay, but the problem is at the level of the
Okay,
velum.
sir.
Okay, so we'll do a zeta for this patient. Then we'll decide. Okay, you can see that this is 63. Yeah, okay, so somebody, sir, can I do a jaw thrust for the patient? Then I tell you. Wait. Oh, don't. When I tell you jaw thrust,
For that only nowadays they do zeta plus. Zeta plus, ZTC, Z plus. Yeah. It's just the English.
okay, do the jaw thrust now. See, when you do the jaw thrust, the velum part will not improve. Okay, but the tongue base part will improve dramatically. Okay, and then you see that the saturation will come to normal. And this pain is bringing the patient also at the higher level of from the low level of low sedation to the better sedation. Okay, so this is the dice. So next we'll do a zetaplasty for this patient. One important thing to talk about is, I was worried when madam wanted me to show dice to the audience, because doing dice with a new anesthetist itself is very difficult, very challenging, because they will not give the proper plane, but they will tell you, they will just push some ducks and tell that's all it's happened, so do whatever you want to do and come out, my job is over. But our anesthetists here have done a fantastic job. But to demonstrate like this, to bring it slowly to the this level, to the level of 60s, and show them what's happening, it's a commendable job. Congratulations to the anesthesia team. This is such a wonderful anesthetist. Thank you very much. Thank you. Right. Oral. Flexometal tube is better. Center. Council பண்ண போறோம் அவ்வளவுதான். அந்த பாக்ஸ் இருக்கு பாருங்க. போட்டுருங்க அவ்வளவுதான். இதுதான் எந்த இது வந்து அடாப்டர், அதுக்குள்ள இன்னொரு இது இருக்கும். பாக்ஸ்ல ஒரு பேட்டரி ஆப்டிகல் லைட். தேங்க்யூமா. தேங்க்யூ சூப்பர். டக்குன்னு கொடுத்துட்டா இட்லி வர வச்சுட்டா தான் டக்குன்னு கொடுத்துட்டோம், அது டக்குன்னு அந்த பிளேன் போயிடும். ஸோ நான் வந்து ஒரு லெவலுக்கு அப்புறம் டேக் த பேஷண்ட் டு தட் பிளேன் எனி டைம் யூ வாண்ட், பட் யூ கான்ட் டேக் அவுட். அது ஸ்லோவாக தான் வரும். அப்போ நான் பார்த்துக்கிறேன். சார்
Sir, what case you are going to start now, sir?
Zetaplasty.
Okay.
Hello. So
Okay, sir. Okay.
We are going to do a zetaplasty. Okay, இது வேணும்.
Sir, what surgery you will do when you have AP collapse?
AP collapse, we'll do actually we do a anterior palatoplasty. But
When there is lateral collapse, sir?
anterior collapse, we do an anterior palatoplasty. Lateral collapse, what
Okay.
you do is an expansion sphincteroplasty. Even for this
Sphincteroplasty.
patient, you can do an expansion sphincteroplasty. But expansion sphincteroplasty, we'll show it on the other patient. So I'm going to do a zetaplasty. Hello.
Okay, sir.
So there are two things we do. The two types of surgeries, like SMR and septoplasty. We have a palatal destroying, uvula destroying surgeries and the uvula sparing surgeries. The advantages of uvula destroying surgery is the disadvantage of uvula destructive surgery is that patient will not have uvula after the surgery. Once there is no uvula, the fluid which comes inside the nasal cavity, nasopharynx, will not go into the oropharynx and it will stay there. Usually what happens is our postnasal drip goes to the uvula. The uvula will touch the posterior pharyngeal wall, and then through the posterior pharyngeal wall, it will go inside. It can't jump from superior surface of the palate to the pharynx. Okay. So, but if you okay, so if that is not happening, patient will always feel that there is some amount of postnasal drip stays in the palate. So he'll always come and complain. Actually, he'll not complain. She will not know. If you go and tell them that hey, it's because of your surgery, if somebody tells them, then always they will come and complain. That's a little bit of tedious for the patient also. So you can do a uvula sparing surgery. But uvula sparing surgery is like your septoplasty. It's not as effective as that of the SMR. Okay. That's the drawback of septoplasty. Okay.
So what will you do when there is a tongue-based collapse?
Tongue-based collapse. Yes, I'll see whether it's a high tongue-based collapse or a low tongue-based collapse. And I do an MRI. MRI will tell you whether there is a tongue muscle bulk is more, or there is a lingual tonsil is more. If the lingual tonsil is more, what I do is with the gallbladder, you remove all the tonsillar tissue, like how you lingual tonsillar tissue, like how you remove the adenoids. Okay.
Okay, sir.
Or you do a if the muscle is more, you do the channeling. Channeling is you approximately identify the two parts.
Channeling.
Yeah, approximately identifying 2 points where there is a lingual artery is coming. Okay. And then in between that, you make a wedge and remove the tissue. That's called that is called wedge resection of a tongue base. Okay. If there's if the same thing has happened, if there is a this tongue base because of the muscle bulk, epiglottis posteriorly, then we'll pull the epiglottis anteriorly by closing the gap between the hyoid bone and the thyroid cartilage. Next thing is, if you have a problem with the retrognathia, then you got a geniohyoid advancement. Geniohyoid advancement is you make an incision at the lower the gingival sulcus at the lower lip near the frenulum, and then remove the periosteum down. You identify the root of the teeth, and below that you identify the area. That's a genial tubercle. That area you identify a rectangular space and cut the inner table and outer table with a drill and pull it anteriorly. So if this is the anterior table of the mandible, you cut this part and pull it anteriorly like this, so that the inner table will come close to the outer table like this. Okay. Then you rotate it in the 90 degree, so that the horizontal plate will become a vertical plate. That will keep the inner table outside the level of the outer table. So that will pull the epiglottis and the tongue base anteriorly, so that the airway will improve. That's called a genial advancement.
So, any surgery you do on the epiglottis, sir?
Epiglottis, epiglottis surgery is done when the epiglottis is flabby and epiglottis collapses, not when the epiglottis is pushed backwards or pushed laterally. The epiglottis is collapsing. I'll show you a video of epiglottis collapse where the epiglottis will buckle inside. If that is the case, if this is like a laryngomalacia. You do a supraglottopexy. What you do is you catch the epiglottis and lift up and cut the area epiglottic fold and cut the excess epiglottis and make the length of the epiglottis smaller so that it doesn't buckle. The epiglottis buckle not because of the length, but it's because the
Flabby.
elastic tissue inside is very flabby, so that it just goes inside. To prevent that, you just cut that place and take it out.
Okay, sir. So in
Populated
nutshell, when you
place-
have, like in nutshell, when you have a anterior anteroposterior collapse, you do a anterior palatoplasty. When you have a lateral collapse, you go for expansion sphincteroplasty. Or if you have a circumferential collapse, you go for zetaplasty. And when there is a tongue involvement, you go for, if there is a lingual tonsil, you ablate it. If the muscle bulk is there, then you go for tunneling. Then if it is posterior with too bulk and tongue pushes the epiglottis behind, then you go for genioglossus advancement. Then when there is a epiglottis, flabby epiglottis, you reduce the size of the epiglottis. So these are the OSS surgeries which we do. Apart from that, yeah, what is barbed wires? There is something called barbed wire.
Barbed wire is a wire which has got spikes, so that you need not suture it. When you take the wire from one place to other place, it stays there. It will not come back. So you pull it, it will stay at the pulled area. The basic surgery for the zetaplasty is you pull the posterior pillar or palatopharyngeal muscle to the pterygoid annulus. Okay, that can be done in various ways. One such a way is do a barbed wire. Barbed wire, you mark various points like W. Okay, you make the bites in such a way that you make a bite on the posterior pillar muscle. Okay, and all these various points you go inside and come out. When you pull it, so that will stay in that same place.
Yeah,
Barbed
it's like
wire,
a purse string.
the purse string is the one where you got to tie.
Yeah, here no need to tie.
Take that purse
Yes,
string, you
sir.
got to tie. Here you just pull it and just leave it. It will not go back.
Okay.
Just barbed wire. Okay, barbed wire looks much easier, but the problem is patient always feels something there inside the oral cavity. So he'll come and complain.
Okay.
If the patient is not complaining, that's the best surgery, easiest surgery. Just like that, you can do it.
Is it absorbable or long? It's a
Hey.
long standing absorbable.
No. It is a long time. It is not absorbable. It don't get absorbed shorter. It forms that fibrous tissue, and the fibrosis occurs later. So it will be there for a long time. 3 to 6 months, it will be there. Okay.
So
டான்சில் மாதிரி எனக்கு இது வேணும் மிஷின் இன்சைட் வந்தால் பெட்டர். ஐ வில் சிட் தேர் அண்ட் ஆப்ரேட். அந்த மிஷின்லாம் எடுத்துடலாம்.
Sir, say hi to Dr. Anbarasan. He is the anesthetist.
Anbarasan, Karthi is saying hi to you. Something special. Why? What's happening? அவ்வளவுதானா? சரி, ஓகே. அவர் என்னுடைய ரெகுலர் ட்ரிப் பார்ட்னர். wherever we go together. இல்ல கார்த்தி? Hello? Karthi, I told him that you are my trip partner. He said he is your anesthetist. I told I am your trip partner. Hey, உண்மையா இல்ல வந்து என்ன விட்டு எங்க தனியா போறியா?
Sir, பாம்பின் கால் பாம்பரையும் sir. What? Hello, sir. Sir, can you hear me? No, no.
Hello, Karthi.
Sir, can you hear me?
Yes, Karthi.
When you are going to start, sir?
Now.
Sir,
கேமரா
theatre picture is not
எதையும்
clear.
ஆஃப் பண்ணாதீங்க மேன். ஆஃப் பண்ணா அங்க ஆஃப் பண்ணுங்க, இங்க ஆஃப் பண்ணாதீங்க. எதுக்கு ஆஃப் பண்ணி வைக்கிறீங்க? எங்க? So we are ready, Karthi.
Okay, sir. Okay.
We are ready. I'm just going to
Sir,
start.
again,
Yes.
sir,
This is the endoscope
we can't
holder.
we can't see both external and hello. Yeah.
என்னாச்சு? Patient is fine.
இல்ல.
அது போட்ட உடனே பண்ண ஆரம்பிச்சிருங்க. ஹெட் டவல். Hello, Karthi.
Hello, sir. Wow.
Can you see? That's an endoscope holder.
இல்ல. Hello. Yes, sir.
பின்னால போ. Zoom out, man.
It's neuro endo holder.
Sorry?
So,
I don't hear you.
the endoscope holder, what is that?
Endoscope holder, what the Taktish gave me there.
Okay, sir.
சும்மா டபுள் போடுற மாதிரியே போடுங்க. ஏன் அதெல்லாம் ஒட்டலாம் வேணாம்.
அவன் பண்ணது.
ஏய்,
ஆமா.
விடு பரவாயில்ல. ஒரு டவல் கிளிப் போட்ட முடியற வேலை. நான் பண்ணிடுறேன் மேடம். See, this patient is obese. More than obesity. Hello? This patient had a adenoid swelling long time. This patient has an adenoid swelling for a long time.
Okay, sir.
So because of the adenoid swelling, what happens is patient will not breathe through the nasal cavity. So when they breathe through the oral cavity, the intermaxillary distance, that will become narrow. Okay, once that intermaxillary distance has become narrow, right? Once the intermaxillary distance has become narrow, can you see here? This distance is narrow. Okay, I'll show you. Once the intermaxillary distance is narrow,
The
what
endo
happens
picture
is
is not there, sir.
No, it doesn't. No, I have not used that endo camera at all now. Okay, I'm just getting myself ready.
Scope in endoscope.
சின்னது கொடுமா, அது கையில வச்சுக்கோங்க. இல்ல இது ரொம்ப சின்னது.
endoscope ரொம்ப காமிக்கிறது.
Okay. Tongue okay. Yes, right. இது கொடுமா. இருங்க. டேபிள் லைட் குறைக்கணும். இது கொடுமா. பட்டன் ஃபோர்செப்ஸ். ஸ்டாஃபி இது என்ன இது பிடிக்கவே மாட்டேங்குது. ஓகே ஓகே சொன்னால யார் எனக்கு அசிஸ்ட் பண்ணா? எப்படியே புடி. ஆடக்கூடாது ஆடக்கூடாது. இதை போடு. இது ரெண்டு கையில ரெண்டு இதை விட்டுரு. நைட்ல போடு நைட்ல போடு. மூவ் ஆகக்கூடாது. ஓகே எஸ் ஆஃப் பண்ணுறோமா?
மேல இருக்கா? Hello, Karthi?
Yes, ma'am.
Now
We are
everything
getting
is
the
arranged.
picture.
Yeah, okay.
Okay.
Now sir has arranged the endoscope holder and he is using 0-degree endoscope
Okay.
with the boiled is mouth gap for opening the mouth.
Yeah, little bit we have to wash the tip of the scope with Savlon.
Okay, done. Will do.
And a little bit fine tuning has to be done. Camera fine tuning. Hello.
Yeah, doing Karthi. That we adjust.
Also,
Oh, no, இது வந்தாவே போதும் பா வர. Now it's clear?
yes, ma'am.
Yeah.
Little bit fine tuning.
Okay. Yes, sir, it's nice. It's fine. Yeah.
Is it okay, Karthi?
Yes, ma'am. Okay. Sir, can you change that Clara Chroma mode to standard and see, sir?
Stool போட்டு உட்காருங்க.
Up. Up, up, up. Yes. Sir, yes. Up. Up, lateral. I think this is much better, sir.
Is it?
Yes, sir. அது
White balance.
நேரோ கேவிட்டில நல்லா இருக்கும்.
நீங்க மிஸ் பைசா வச்சிருக்கீங்க வேணா.
எடுத்து போதும். உங்களுக்கு வேலை சொல்ல அது மட்டும் தான் தெரியாது. டெமான்ஸ்ட்ரேட் பண்றோம் மேடம். நம்ம டெமான்ஸ்ட்ரேட் we are demonstrating whatever they are happy we are happy. ஏய் எங்க மேன் அது சௌமியா என்னோட கிளினிக்ல அது போட்டு அங்கேயே உட்காந்துக்கும். ஏன்னா 4 வச்சிருப்பேன் நான் டிப்ரேடர். அது இங்கே வேணும் இல்லை டுவர்ட்ஸ் யூ புல் டுவர்ட்ஸ் யூ இன்னும் இழு இங்கே வேணும். எஸ். ஸோ திஸ் இஸ் அடல்ட் டான்சில். சவுண்ட் சவுண்ட் எங்க பாருங்க. ஏய் பார்த்து ஏய் எஸ் விஷயம் நீ தான் பார்க்கலாம் இது. Can you see the plane? Karthi?
Yes, sir. Yes, sir. Yes, sir.
That's the plane you want to operate on.
So picture. So suddenly picture quality changed. Yes. Now it's frozen. Audio visual.
Hey, light in the side, endoscope, endoscope, endoscope.
So why can't you relay with the microscope, sir?
Why I read with the microscope?
No, no. I think it is difficult to use endo holder along with headlight.
No. You know I'm an endoscopic ear surgeon. That's why.
It's okay, sir, but here reflection, everything is coming.
See, the picture quality will be better with this. I'll show the recorded. See, you can see the plane here. Can you see the plane?
Yes, sir. Yes, sir.
Such a nice plane you can see with the endoscope. Not, you can't bend the pictures. No, in a microscope, see, you can go near and see this. That you can't do with the endoscope.
Microscope.
Sorry, microscope. Microscope is very fixed. The same thing like how we do a endoscopic ear surgery, how it is good. The same way.
சரி அது வந்து வெசல் பின்னாடி தெரியுது பார்த்தீங்களா அது கொயாகுலேட் பண்ணி கட் பண்ணால் ஈஸியாக போயிடும்.
இரு.
நல்லா சொல்லுங்க. Hey, light. I don't see properly. Hey, Nipa, light. Fellow called Sati, yeah? வசதியான வீடா உங்களுக்கு ஒரு பெட் வாங்கிட்டு வந்து வைங்க வீட்டுல இருந்து
ஒரு பெட் வாங்கி வந்தா வீட்டுல இருந்து சசி கேன் ஸ்லீப்ல க்ளவ் போட்டு படுத்து சசி தூங்குதேன்னா பீச் அனுப்பிச்சுடலாம் சசிய கேஸ் முடிஞ்சோடனே ஏய் ஓவர்டா கிளம்புறானா கிளம்பிடுவான். ஓகே ஓகே காஃபி டான்ஸ் எடுத்துட்டு எப்படி பேக் வைப்பீங்க அதே மாதிரி பேக். இது ஏன் இழுக்குது இவர் எல்லாமே இங்கதான் இருக்கணும். ஏய் பாரு இதுதானே நீ பார்க்கணும். காட்டன் பேக் 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 பேக். See, when you are doing a zetaplasty, when you are using a zetaplasty, you are not bothered about the bleeding. Why? Zetaplasty is nothing but a glorified pillar dissection. Pillar suturing. You are going to take out the posterior pillar and suture it to the anterior pillar. Okay, so zetaplasty bleeding, we are not much bothered. Okay, so when there's a bleeding, what do? You check the bleeding. If the bleeding is not controlled, you do a pillar suturing. So here we are going to do the pillar suturing straight away. Okay, Safi, 3 cotton ball. Giving it. Safi, cotton ball count வச்சுக்கோங்க. Okay, so actually this is what is our area of interest. Okay, so this is our posterior pillar. We are going to bring this to, this is the pterygoid annulus. Okay, so this tissue should, we remove all this tissue and cut this and bring it to this place. எப்பா தம்பி யாரும் இன்சைட் நந்து வராதீங்க, இங்க இருக்கவங்க அன்சைட் போவாதீங்க, அன்சைட் இருக்கவங்க இன்சைட் வராதீங்க ப்ளீஸ். ஓகே, இவனை இப்படி பிடி. ஓகே, இதே மாதிரி பிடிக்கும். இதுவா வேண்ட் இப்படி எடுத்துருவா. ஓகே
ஓகே சார்.
இது கையில் பிடிச்சி போய் கரெக்டாக ஆடாமல் பிடிக்கும். இது மாதிரி இப்படி வச்சு பிடிச்சிக்கோ, கையிலே பிடிச்சிக்கோ. ஸ்டஃபிங் காட்டன் பால் ஸ்ட்ரைட் எடுக்காதீங்க. இங்கே இது காட்டன் பால் ஸ்ட்ரைட் எடுக்காதீங்க. இது இன்னும் 2 போடுங்க. மொத்தம் 5 காட்டன் பால் போட்டிருக்கீங்க. கணக்கு வச்சுக்கோங்க. 5 தான். 5 5 போடுங்க. பில்லடி செக்டர். நீ எடுத்துறேன். இதுலேருந்து எடுத்துரு, அப்படியே எடு. இதுலேருந்து எடுத்துரு. நேரத்துக்கு வேலைக்கு வந்துடும். இது 20 நிமிஷம் எடுத்துட்டு போய் நேரம் வெளியே வந்துடும். செக்ஷன் லைட். ஸ்டாப்பி. இது எங்க நேஷனல் செக்ஷன் எங்க கவுன்சில் செக்ஷன் நிற்கணும்ல, போடுங்க. டேக் திஸ் அப். உன்னோட வேலை இது பிடிக்குது மட்டும்தான். எல்லா வேலையும் எல்லாரும் செய்ய முடியாது. உனக்கு கொடுத்த வேலை இது, அது ஒழுங்கா செய். ரொம்ப உள்ள போயிட்டேன்னு நினைக்கிறேன் நீ. என்ன மேடம்? Okay?
Yes, sir.
Right. So now you go for the opposite side. Okay?
Okay, sir.
Valsanam. இல்ல அது பரவாயில்ல, இதுக்குள்ள போட்டு வச்சா லைட்டா. ஃப்ளஷ் பண்ணீங்களா?
7011. Okay.
I told you in the morning, Right side, which side you first? That's the best case to operate. Best van to operate. So you can see, to compare with the opposite side, this side the cutting speed will be lesser.
Okay, sir.
நான் ஆப்ரேட் பண்ற இடத்துல இல்ல. எஸ். This is very buried tonsil. இது யார் இது? மேடம், இந்த கோஆபரேட்டர் யார்? ஏய், இது மேல இருக்கிற அந்த ஒயரை இதை வந்து ஏன் வந்து எதுல மறிக்கிறீங்க? ஆமா, அது 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 மூவ் ஆயிட்டே இருக்கும். இது கிடையாதா? ஏமா பண்ணி முடிச்சவனே எடுமா. The point is you should maintain the posterior pillar. That is very important. The posterior pillar.
Okay, sir.
Okay. I don't like to coagulate with this because when you coagulate, there will be a suction will be there. This suction This suction will suck the soft tissues inside this. Soft tissue will go inside the tonsillar vents and okay.
Gets
So
blocked.
with this, you go for a xenoplasty. Okay.
Okay, sir.
யூவலா மிட் லைன்ல எப்படி இருக்கணும்?
இதை எடுத்துட்டு சார் அந்த போஸ்டர் பில்லர் எடுத்து இப்படி இந்த பக்கம் வைக்கணும்.
எனக்கு ஓகே. பைபாலர். ஸ்டாப் நீங்களே வச்சுக்கோங்க. See, I can use the மேலந்து வா. லைட் கரெக்டா பண்ணணும்ல. டச். எவ்வளோ வச்சிருக்கீங்க? டச் 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 இது பாரு பிளேட் போடு இதை எடுத்து இது பாரு நீ உள்ள விட்டு கையில் கொடு. லைட் இருக்கா? லைட் இருக்கா?
Sir.
value adjusting.
மன்சாரி கிட்ட ஒரு ஹெட்லைட் வாங்கினேன். ஊருக்கே தெரியுது.
Touch. Touch. Touch.
Hmm? Sir, do we have endo picture? No.
See, actually, the endo holder is obstructing my view. So I have removed the endo holder and controlling the bleeding. Touch. Sophie, call எடுக்காதீங்க.
So I think there is a problem with band.
Yeah, the problem will definitely. No, I'm not using band. Why I'm not using band is when you cauterize like this, there'll be a suction attached to the band. Okay, so the tissue will go inside and tissue will get
Yes, sir.
blocked. If I'm doing tonsillectomy, that's fine. But now I'm going to do a Zeta, so I need the band again. Touch. Okay, right. Now you take the endoscope. இதுதான் view. என்ன நடந்தாலும் உன்னுடைய கை இப்படி இருக்கணும். இந்த கை இந்த படம் இப்படி தான் இருக்கணும். இது யார் ஆஃப் பண்ணா? ஏய் உள்ள 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 நான் சொன்ன மாதிரி வை, அங்கிருந்து எடுக்காத. நான் சொன்ன மாதிரி வை, அங்கிருந்து எடுக்காத. Okay, so now you see the anterior pillar. That's the posterior pillar.
We are not getting endo picture.
யாரா
Sir, we don't have endo picture. Sir, now we have.
So this should come here like this. Okay.
Okay,
So
sir.
to do that, first thing you should see is the hot palate, soft palate junction. So that's a hot palate, soft palate junction. This is base of the uvula. You take midpoint. Hey, on the man, kudu man. This is the palate band. இதையும் எடுத்துறாதீங்க, இதையும் அப்படியே வைங்க. அது வேலை செய்யுமான்னு தெரியாது. Okay, so this is the I show you pterygoid annulus. Okay, so this is the bony soft palate hot palate junction. This is base of uvula. In between there's a midpoint.
Okay, sir.
அதான் தூக்கி போடுங்க சிஸ்டர்.
the rough and ambulance
இது
அது இப்படி
அவ்வளவுதான். Okay, so this is the where yaar.
So what's the name of this van, sir?
This is pallet van. மேல் டிப்ல இருக்கு பாருங்க மட்டும். எடு. இது 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 எடுக்க தேவையில்லை. Okay, so this is the terminate van. I mean, sorry, this is the pallet van. Okay, so before doing this, I want to show you, this is the posterior pillar muscle. This is the posterior pillar muscle.
Okay, sir.
Okay, so when you do an expansion sphincteroplasty,
Palatopharyngeus.
so you take this muscle and dissect this muscle out. Okay, then cut here and then take this and stitch
sir.
here and make a tunnel. The stitch should come here and come attached to the pterygoid annulus. If you do this, see what happens to the uvula. It has come anteriorly, right? This
It's
comes
pulled.
anteriorly.
Anterior.
Okay, similarly, instrument. See the opposite side. You dissect the posterior pillar, stitch it here. Go inside here. Anterior. You can see the amount of tissue which goes laterally. Okay. No, post-nasal space pattern. Post-nasal space. Okay, so your airway will improve. This is called zetaplasty. But this is called expansion sphincteroplasty. Take it out. So this will
Expansion sphincteroplasty.
So this will not be as good as that of the zetaplasty. Okay, my favorite is the zetaplasty only. So I'm going to do, how do you do a zetaplasty? Okay, first thing is, you take the van, take the midpoint. So take the midpoint. You make the dot. Okay. So you make multiple dots like this. Wait. Go to the anterior pillar. Hey, it's not working. I don't like this. Take it out on the van. On the van. Eppa, தம்பி இத மாத்தி போடு. அது கேவலமா இருக்கு. டேபிள் ஹைட் குறைக்கணும். Full table down. Stool increase. Stool. mana தேவல. Okay. ஏன்டா தள்ளி விட்டுறீங்க இதை? எனக்கு இங்கே வேணும். ரைட். இங்கே பாரு, இங்கே வேணாம் மேடம், நல்லா இருக்காது மேடம். இது நான் எப்போ பண்ணுறது, புதுசாக பண்ண வேணாம். இது பிளாக். சக் பண்ணா பாருங்க. செக் பண்ணுதா? அது செக் பண்ணான்னு பாருங்க. அது செக் பண்ணான்னு பாருங்க. யார் ஆஃப் பண்ணா? எவ்ரிபடி. இப்போ அதை எதையும் ஆஃப் பண்ணிட்டு எதையும் இதுவும் பண்ணாங்க. ஓகே, ஸோ இதான் இது. அம்மா என்னம்மா நடக்குது இது? இரு எங்க அவன்? எங்க போன நீ? அவனை கூப்பிடு, இங்க வாங்க. எங்க போன நீ? பேரம் இல்லையா உள்ள? இது வேற வேலை செய்ய மாட்டேங்குது.
இந்த புகை இருந்தாலே
உன்னோட பொசிஷன் மாத்திர நீ. எத்தனோட எல்லாத்தையும் கனெக்ட் பண்ணு. முதல்ல அதுல எல்லாத்தையும் கனெக்ட் பண்ணு, அப்புறம் மாத்து.
பக்கத்துல போனாலே.
So this butterfly area got to be ablated. So this has got a lot of subcutaneous mucosal glands. All these mucosal glands should come out. ஏய் ஆடக்கூடாதுடா. Okay, you can see the muscle here.
Okay, sir.
The muscle is the one which is bleeding.
Then
Okay, so similarly you got to make another butterfly here, this side.
okay, sir.
அது இன்னொரு வேண்ட் வேணும். இட்ஸ் நாட் ஒர்க்கிங். இது புது வேண்டா, இந்த கேஸுக்கு போட்டோம். அதிலே போட்டுடலாமா? அதிலே போட்டுக்கலாமா? Ready? So this is the difference between the new wand and the old wand. Okay. I want 2 straight artery forceps. So I remove all the
Mucosa.
filler dissector, bipolar. ஏன்டா ஊத்துது இது? சக்ஷன் வரலன்னு அர்த்தம். சக்ஷன் வருதா பாரு. ஏடிது? சக்ஷன் வருதா? ஏய் கை வச்சு பார்க்க தெரியாதா ஒரு சக்ஷன் வருதானே? வருதா இல்லையா? அப்ப போடுது. ஏன் தண்ணி வருது? நீ அழுத்தி நிக்கிறியாங்க. அப்படி பண்ணுங்க, வேற வேலை செய்யாதீங்க, வேற வேலைக்கு வா. ஏய் தண்ணி வருது மே. என்ன வச்சிருக்க மிஷின் நீ? அது போடாத, இதை போடு. அது வேண்டாம். அப்புறம் ஏன் தண்ணி வருது? Touch. The problem here is bringing a new machine, and the new machine they want to demonstrate in spite of everything. Touch. Okay. Not. Touch. 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 Touch.
Cotton balls வேணும் stuff. நிறைய cotton balls வேணும். இதெல்லாம் எடுத்துடணும். புதுசு இதில் போடணும்.
Touch.
ஸ்டாஃப் யாராவது கூட வர சொல்லுங்க ஸ்டாஃப். நீங்க டச் பண்ற வேலையை மட்டும் பாருங்க. இல்ல வேற யாரையாவது டச் பண்ண சொல்லுங்க. எல்லாத்தையும் நீங்களே பண்ண முடியாது.
Touch. 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 Touch.
தண்ணி ஊற்றணும் ஸ்டாஃப். டச் பண்ணா பிஞ்சு வருது. இது க்ளீன் பண்ணி கொடுங்க.
Touch. 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 Touch.
ஊற்றுங்க ஸ்டாஃப். அங்கேயே ஊற்றுவீங்க.
Touch. Touch. Touch.
தம்பி ஊற்ற தெரியுமா உனக்கு? டச்.
Touch.
சக்ஷன்.
Yeah. My wife had a classmate. So now you are dividing the uvula.
Yeah, I am dividing the uvula along the line I have made. Okay.
Okay, sir.
If the uvula
Two
is, this
equal
uvula
parts.
is not very big. the uvula is big, you can cut the uvula off also. Okay.
Okay.
So you cut the uvula. Okay.
Okay, sir.
You cut to the point of where you make the அவ்வளோதான்
First.
ஆமாம் சூச்சரிங்க்கு வந்து குரோமிக் இல்லை ஐ மீன் சாரி வைக்கிள் 30 வைக்கிள் மோனோக்ளோ இல்லை வைக்கிள் தான் ஓகே ஸோ வி ஆர் கட்டிங் இயர் in such a way that you can suture it to this part. Okay.
Okay, sir.
That's a zetaplasty for you. The drawback is the patient will not have uvula, so whatever fluid comes here, it will not go there. But advantage is it gives the maximum amount of expansion. Pull little.
Okay, sir. அப்படியே
Hold this. Hold அங்க பார். Okay. Okay, so the anteriorly little bit you open, it should be fine. Okay, so this should come.
இதெல்லாம் ஸ்டார்டிங்ல கோல்ட் ஸ்டீல்ல தான் பண்ணாங்க
Wait. போதும் இதிலே போட்டுக்கணும்
She cooperated easy. Provided van இருக்கணும் புது van. சார் நோஸ் 2 நிமிஷம் யூஸ் பண்ணி வேண்டு வேலை செய்யலாம் சார். நீங்க 11000 ரூபாய்.
இல்ல மேடம் நம்ம இது பில்லர் சூச்சரிங் தான் பண்ண போறோம். ஓகே. So புரியுது. You take a thick bite here. Coffee, simple stuff. குட்டி நீல் சொல்றாந்தா இப்படி போடக்கூடாது. ஓகே. Take a deep bite in the pterygoid annulus. Okay. நீ உள்ள ரொம்ப எடுத்துட்டு போற இது நீ உள்ள ரொம்ப எடுத்துட்டு போற நல்ல வெளில இன்னும் வெளிலவா பல்லு மேல வைக்காத straight artery. No. Straight artery. Stay போட போறேன். ஏதோ ஒரு
இதை கட் பண்ணுங்க. மஸ்கிட்டோ வரலம்மா. So this is one side. Okay.
Okay, sir.
இந்த சைடுல இருந்து இந்த ஃபோசாக்கு இந்த சைடுல இருந்து இங்க பாருங்க. இது மாதிரி சின்ன ஆர்டரி கொடுத்தா இங்க கட் லைட். You hold it like this. Can you see? Can you see this?
Yes,
you
sir.
hold it like this. Taking bite will be much easier. யாராவது ஒருத்தருக்கு பிடிச்சி எடுத்து கொடுத்தா எனக்கு ஈஸியாக இருக்கும். ஓகே, அவன் வேடி பார்க்க வந்திருக்கான் சிஸ்டர். இது ஒரு ஸ்ட்ரைட் வச்சுக்கோங்க. வேணாம் மேன். ஆன்டி ரெபிளில் பிடிப்பியா? ஆன்டி ரெபிளில் எதுக்குடா எனக்கு பிடிக்கணும்? எனக்கு நேரம் தெரியாது. ஃபோர்ஸாக்குள்ள தான் எனக்கு ஹெல்ப் வேணும். வேண்டாம். Can you see now how much is the expansion you have got now? Okay.
Yes.
That's a fantastic. Ask the anesthetist, she will tell you when they put a வலிக்குது, கை வலிக்குதா? Scissor. One more. மூணு.
ஒட்டிக்கோ.
கீழே ஒன்று போடணும். மேடம் இந்த சைடு வந்துருங்க மேடம். இந்த சைடு ஸ்ட்ரெயிட் ஆர்டர். I'll go from the other way around. From the pterygoid annulus, we make a bite. மேடம் நீங்கள் இங்கே பார்த்தா அங்கே படம் தெரியாது, இங்கே பார்த்தா படம் அங்கே தெரியாது. அங்கே பார்த்தீங்க அங்கே அதான் கரெக்டான இடம். அங்கே வச்சுக்கோங்க. ஸ்ட்ரைட் ஒன் போட்டுக்கோங்க. ஆக்சுவலி இந்த சைடு ரெண்டு, அந்த சைடு ஒன்று. ஸ்ட்ரைட் போட்டுக்கோங்க. இதை கட் பண்ணி பைட் கொடுங்க. என்ன மேடம்? நீங்கள் எடுத்துறீங்களா? இங்கே பாருங்கள். வாங்க இங்கே பாருங்க, இங்கேருந்து இங்கே ஒரு பைட்டு, ஓகே, இங்கேருந்து இங்கே ஒரு பைட்டு, அப்புறம் இங்கேருந்து இங்கே ஒரு பைட்டு, இங்கேருந்து இங்கே ஒரு பைட்டு. ஓகே, the 3 bytes you got to take. So 1 byte here, 1 byte here, and another byte here. Okay.
Okay, sir. That suture material is 10 or 20, sir?
0.
10 or 20, sir?
30.
Okay.
Okay. Let's do this. இந்த டிப்ல
வாய்க்கு.
அதே மாதிரி இங்கேருந்து இங்கே, இங்கேருந்து இங்கே. ஓகே. See, before see, this is the so this is the oropharynx. You can see the gap now. So this will go laterally, this will go laterally, and there will be a huge amount of gap behind the and the edge will get lined by the you can see the mucosa. So the undersurface is lined by mucosa so that it will not go for pharyngeal stenosis. That's an idea of doing the zetaplasty. Okay.
Okay, sir. Okay, sir. So post-op, do they keep the endotracheal tube for one day or they remove?
No, that I leave it for the institute's policy. But generally speaking, I extubate the patient immediately and send the patient when you do it outside. But you know that these cases I do only in bigger hospitals like Mehta or VS Hospital, where they have a good post-operative setup. But in a smaller nursing homes, it's safer to keep the tube for a day. But MMC, they will keep the tube because they have everything. Okay. They have huge battalion of people to take care of post-operative. They have a PICU, so they will keep the tube for a day. But you know, outside you keep the tube for a day, it will cost you more money.
Okay, sir.
And the patient will extensively go into the anesthetic stance, which is very difficult for us to manage. For example, I did a total laryngectomy and sent the patient into the post-op intensive care ward, anesthetic intensive care ward. What happened after third day? My colleague came and told that the patient is having bleeding from the puncture wounds, that bite wounds. I went and saw the patient was under, it was bleeding. I asked, what's happening? He said they have given the patient heparin. And they said it's a policy that all the post-operative patients will give DVT prophylaxis, and they gave heparin.
Yes.
I told them no heparin. They said no. In PICU, it's under our care, and I'll give only heparin. Then I saw, imagine the third post-op day, patient has got 3 tracheostomy tubes. Hello?
Okay, okay.
You have 3 tracheostomy tubes. I asked them, why 3 tracheostomy tubes? They said, no, every day you got to change the tracheostomy tube. And you know the tracheostomy tube, how much it costs. I told shift the patient to what? I'll take care. No issues. So, safer to keep them inside the anesthesia, under the anesthetist care. Sometimes it's better to have it on your hand itself. Okay, so the bigger hospitals, well-learned anesthetists, they have their own policies, and that's very, very difficult for us to follow.
Okay, sir.
Okay.
Hello?
Yes.
Sir, can we do the same procedure with the laser?
Sorry? Same
Can we do the same procedure with the laser?
No, it's very difficult to do it with the laser. Laser, they do only LOP. They don't do an expansion sphincteroplasty. You can do it with the radio frequency. Again, actually, you can do it with the radio frequency, not with the
laser. Laser takes longer time to cut the palate. It takes very long time. Sir, you know, as tonsillectomy itself is very difficult. And cutting a soft palate across will be very, very, very difficult for us. I have not tried, I have not heard that it's been done with the laser.
Right. Thank you, sir.
Okay. The laser used in this thing is for somnoplasty and lob.
So is the case over?
I am
Sir,
feeling very tired.
is the case over?
So just no, no. I'm
Is the case
I'm
over,
feeling
sir?
very tired. No, 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 no. I am getting very tired, so I just wait for 2 minutes and then I'll finish that suturing. Just 2 minutes.
Okay, sir.
நீங்க இப்படி எடுக்கணும் பைட்டு. இங்க பாருங்க. இப்படி எடுக்கக்கூடாது. இப்படி எடுக்கணும். Hello?
Sir?
Since I am feeling tired,
Okay,
Madam
sir.
is doing the final suturing.
Okay, sir. Show the final pictures.
Yeah, once it's over, I'll show you.
Okay, okay, sir.
சும்மா சொன்னேன். இதான் நார்மல்.
Hello, OT. Hello, OT.
Yes.
Sir, is there any more case there or it's the last
Yeah,
case?
we have a half an hour gap for taking food. Have you had your food?
No, sir. Sir, shall I finish this session?
Yeah, 1 minute. I will show
Or,
you the final.
yeah, show me the
I'll show
final
you
pictures.
what is the good lateralized expansion. I'll show you. Then we can show almost case is over.
Okay, sir.
Okay, almost case is over.
Okay, sir.
Beautiful. Okay, answer போட்டிங்களா? நான் அது காமிச்சிடுறேன். Endo picture, please. உட்காருங்க. You can see. You can. Karthi, can you see this? Karthi?
Yes, sir, I can see.
So this is the lateralized
Wall, posterior pillar.
posterior pillar. When you lateralize it enough, you can see a small ridge here. Can you see this ridge? Can you see this ridge?
Yes,
When
yes,
this becomes taut,
Yes.
this is a.
Yes,
Can you
yes.
see there? That's the Pesavans ridge. Okay.
Yes, sir.
So when you have
Okay.
laterally, when you have pulled the pharynx enough, you get this become thicker. Okay. So you need
Sure.
one more bite here. Then we'll close this case. We'll have a short break. Then we'll do a terminate. Okay.
Okay. Okay, sir.
Right. Thank you.
Thank you, sir.
Terminate and the posterior chorotomy.
Okay, sir.
Thank you. Thank you, everyone. Thank you.
Thank you, sir.
Thank you, sir. Now I request Dr. Mahindran, sir, to honor Dr. Meja Karthikeyan, sir. Please, sir. And I request Dr. Natarajan, sir, to honor the moderator, Dr. Sembian Chakravarti, sir. Please, sir. Thank you, sir. I request everyone to have their lunch. There is an half an hour break. Thank you.
கவர் அங்க போயிட்டு அது ஃப்ரிட்ஜில் போட்டுடலாம் ரோஸ் எல்லாம் அந்த பிளேட்டிங்
The next live surgical session is about to start shortly. And for the next session, I welcome Dr. Prabhu Sir, Senior Assistant Surgeon, Atur, and Dr. Shankar Subramaniam Sir, ENT Consultant, Apollo Hospitals, Ranipet, as moderators. Please, sir. A kind announcement. The following vehicles are parked in the OP block. Since the OP block is going to get closed within 5 to 10 minutes, I request them to move their vehicle. 7321 Wagoner and 8043 Harrier. Please. Thank you.
Hello. Can you hear me? அங்க வேணாம் விட்டுருங்க அது போதும். வெளில வந்துடும் மேடம். உள்ள போனா சரியாயிடும் மேடம். எம்மா எப்பா யார்ப்பா அது போட்டிருந்தாங்க? சைட்ல 2 படம் போடுப்பா. ஓகேவா?
Sir, good evening, sir. Prabhu and Shankar, sir.
உள்ள போயிடுச்சா? ஆட்ரி போடுங்க அதை. சரி எங்க அது பாவம் அந்த பொண்ணு கிட்ட சொன்னேன் நான். உங்ககிட்ட எல்லாம் சொல்ல நினைக்கிறேன். Who is there on the auditorium? Can I see who is on the chair? ஏய் கேக்கல. யார் பேசுறான்னு கேட்க சொல்லு. எப்பா யார் பா ஆடியோ விஷயல? ஆடியோ கேக்கல. See? Okay. ஆடியோ விஷுவல் என்னம்மா இது கால்? ஏய் இதான் என் காலு. நீங்க எனக்கு கேட்கல. என்னவா?
Sir, yes, audible, sir.
ஏய் அவங்க பேசுறது எனக்கு கேட்கல.
Available, sir.
இப்பதான் கேக்குது. Who is the moderator there? Hello?
Sir, good evening, sir.
Who is the
Sir, good evening,
moderator
sir.
there?
Prabhu and Shankar, sir.
Sir, good evening, sir.
Shankar
Audible, sir. Sir, Shankar here and Prabhu, sir.
Hey, Shankar,
evening,
Prabhu,
sir.
this is one of the toughest cardiotomy cases I have seen. You can see I couldn't see the card at all.
Yes,
okay.
sir.
So I'm going to start
Yes,
the
sir.
case
Yes, sir.
now.
Yes, sir. Yes, sir.
So I'm going to start from the
False card to
false focal cord. I open up the card now. Okay.
yes, sir.
So you open up the false focal cord. You will get the cord will become visible.
Yes, sir.
Sir, is it possible to zoom a bit?
Zoom little. Okay.
Hello?
Yes. 1 minute. I'll do that.
Yes, sir.
Okay.
Full picture.
So for the audience here, this is a case of papillary carcinoma thyroid underwent total thyroidectomy 6 months back, followed by radioiodine uptake.
Okay. So you can see slowly the cord is getting cut. So if you leave like this, it will go for sin AK. Okay. It's a very small defect, but this is the destructive surgery. So what you do is, you can underdo the case, but you can't overdo the case. Why I am telling you this is this fellow. I mean, this man is he's a professional voice user. He's a teacher. He's a lecturer. He needs voice very much. So what is ideal is you remove little bit of posterior cord so that you should have a good voice as well as you should have a good airway. The airway is not sufficient, you can redo the case. But your voice is not sufficient, you can't do anything about it. Okay. So I don't want to straight away go and remove the lot of tissue for this patient. Can you see now? So that's the cut end of the cord. எடுத்துருமா?
Yes, sir.
That's the cut end of the cord, and that's
Yes,
the
sir.
true vocal cord. This is false vocal cord. இது கட் பண்ணா அது ஓப்பன் ஆகும் மேடம். அதுக்கப்புறம் அது கட் பண்ணலாம். ஓகே.
Yes, sir.
Okay. See, actually, this is the cartilage. So this is the vocal process.
Yes, sir.
Okay, so that's the vocal process. Can you see? That's the vocal process. This is the false vocal cord, which is cut.
Sir,
சிஸ்டர் கொஞ்சம் இது கொடுங்க, ஒரு கப் ஃபோர்ஸஸ் கொடுங்க. So you can see this is the vocal cord. Can you see the vocal cord?
Yes, sir. Yes, sir.
I think that அது ஏன் டிரான்ஸ்மிஷன் அவ்வளோ போரா இருக்கு? Can you see? So that's the cut end of the vocal cord. So that's got
Yes, sir.
retracted. This is the false cord. I am
Yes,
retracting
yes, sir.
the false cord now. Okay. So that is the okay. Now you can see the gap. Okay.
Yes, sir.
This gap may not be sufficient, but the issue is this gap will maintain his voice. If there is a vocal, if you can't decannulate the patient, then you can always redo the case. Okay.
Yes, sir.
ஒரு adrenal cotton ball.
Sir, how will be the voice fatigability post-op, sir?
This patient, actually morning what the case we did, they will have a serviceable voice. Actually this patient had a very good voice. That's what we are worried. He's a professional voice user. He had a very good voice. By giving an airway, you should not reduce his voice below a level. Okay. Huh?
Yes, sir.
But main thing is he doesn't want the tracheostomy to continue. So we plan to remove the tracheostomy. Now you can see. So that's a false cord. No, that's a true
Yes, sir.
cord. And that's
True
a
cord.
false cord. See, what you see is the false cord. That is true cord.
Yes, sir. Yes, sir.
Okay, it's actually it is cut. And we hope this get retracted enough so that the patient will ஒரு இதே மாதிரி ஒரு காட்டன் பால்ல travel patient gets better airway.
Yes, sir. Sir, can you please defog, sir?
Yeah, I'm doing that now.
Yes, sir. Thank you.
Sir, Anthony, sir.
Yes.
This is Dr. Nagendran.
Nagendran,
Sir, here
Nagendran.
I can able to, sir, here I can able to appreciate the edema or along the whole false cord as well as arytenoid.
Yes.
How we can assess in the morning case, we can easily able to appreciate the probable site of vocal process. Here I can't appreciate where the anterior, that is the vocal process of arytenoid is there. I think it is in the middle of the. It is in between the anterior half and the posterior half.
Can you see the
range
can
only
you see the vocal process? Can you see the vocal process?
Sir,
See,
sir,
what I am
picture,
catching
please,
is
sir.
the vocal process. See, that's the vocal process. See, what I am having it in my
Okay, sir.
forceps. That's the vocal process. Okay.
Okay, sir.
So
Okay.
this is one of the difficult cases. That's what I told you. In Stanley, we used to
Okay,
do a
okay,
lot of
sir.
posterior colonotomy cases where
Okay, sir.
these two chairpersons now they were assisting me there. So that's what I told
Okay,
them.
sir.
They will not be happy, satisfied seeing these cases. That's what I was
Yes, sir.
worried. So, but the idea is we have cut here. You have a small
Okay,
gap
sir.
here. Okay. So
Okay, sir.
this gap, you should go up to the level of the inner perichondrium of the arytenoid. I mean inner perichondrium. I will show you
The
now.
thyroid. Yes, sir.
Of the thyroid. Okay.
Yes,
Hold
sir.
this.
So we have to assess the patient, how much voice he should have. We have to counsel the patient whether he may need a surgery, revision surgery. Everything has to be explained, sir.
Yes. See, I have very difficult customers with me here. Okay.
Yes, sir.
Madam is telling me go cut that band also. Even if you people say okay, madam will not allow me to do if she is not satisfied. That's the problem.
Okay, sir. Okay,
Okay.
sir. Yes, sir.
Okay, madam. Okay, so that's the inner perichondrium. Madam will sit down and palpate and
Yes,
get
sir.
it
Yes,
confirmed
sir.
whether it's inner perichondrium or not.
Yes, sir. Yes, sir.
Okay.
Yes,
Yes,
sir.
sir. Yes, sir.
So you can see the inner perichondrium. That's a posterior
sir.
chorotomy. Okay.
Yes, sir.
ஒரு அடியில் காட்டன் பால் எங்க வச்சுட்டு you'll come out. கொடுங்க அது உள்ள போகாது. Okay. Stuffy, what is this? என்ன வச்சு கொடுத்துருக்கீங்க? Plain. Okay. Madam wants to remove all the RBCs. நீ தானே மேடம் வைக்க சொன்னீங்க சின்ன காட்டன் பால். ஓகே. வச்சோன்னே வருது.
Sir, any special maneuver you did while positioning the patient, sir?
What?
Sir, during the insertion of the scope, initially, the position of the patient, any particular modification of the usual maneuver you did for this patient, sir? Because since it was difficult to visualize.
We got a short neck, we got a sandbag. That's all. Stuffy, ஒரு உள்ள வைக்கிறதுக்கு ஒரு இது கொடுங்க. சீக்கிரம். காட்டன் பால். Stuffy, காட்டன் பால் ஒழுங்கா பண்ணுங்க ஸ்டாஃப். We can see the cord now. Okay.
Yes, sir.
Okay, that's the edge of the cord.
Section. அதனால உள்ள போடாதீங்க. Cotton ball. பத்து காட்டன் பால் பண்ணுவீங்க. Okay. எத்தனை மேடம்?
Now we can see the cord better. Okay.
Yes, sir.
I don't think it is the ideal case to demonstrate. Okay. Actually, we find it very difficult to see the vocal cords. Then, ஒரு ஓகேவா யாங்கூர் ஓகே வெளியிலே போட்டுடலாம் யாங்கூர் வெளியிலே போட்டுடலாம். Okay, so this is the posterior corotomy. Is it okay?
Yes, sir. Yes, sir. Compared to the preoperative
Shankar,
picture,
so-
this is clear.
Okay, Shankar, thank you. So nice of you to come from all the way and take a
Sir,
photograph
all
with the
honor, sir. Honor.
take a photograph of you two with the screen. Me
Yes,
on
sir.
the screen. I'll go tell everyone, look at my chairpersons. Thank you everyone. Thank you everyone. Stop it. Thank you, madam. Madam, thank you, madam.
Okay.
Thank you, madam. Thank you. Expansion. யார் டான்ஸ்ல பண்ணுங்க, அப்புறம் நான் பண்றேன். வரல இந்த நாட்டுக்கு.
Sir,
Yes. Yes. Tell me.
just one pose for the camera, sir.
Okay.
Turn to your left, sir.
Sorry.
See the camera. See the camera, please.
Sir, they want to take a photograph, so see the camera so that they can take a
Okay.
picture with your student as a moderator.
Our usual dialogue, sir. வரலாறு முக்கியம் அமைச்சரே.
வரலாறு முக்கியம் அமைச்சரே.
Sir, coming back to the case, if a patient has the history of aspiration with bilateral abductor palsy, how should we proceed, sir?
Hello.
Hello, sir. Am I audible, sir?
I couldn't hear you. You asked something about bilateral abdominal palsy.
Yes, sir. If a patient has aspiration, history of aspiration, so how should we proceed, sir?
Patient has history of aspiration, I told you in the morning. So you got to decide whether it is a structural problem or a functional problem. The aspiration comes because of the there is a posterior glottal defect or it may become as a part of a falling forward of the arytenoid due to a vocal cord palsy. What you should do is you do a functional functional esophageal swallowing therapy. Okay, functional esophageal swallowing therapy is called FACE. So they have a lot of techniques like head thrust technique. They will lift the patient's head, put it forward, and let them swallow. Second thing is they call a pyriform fossa swallow. There are various techniques of there. So you got to send the patient. It's basically like a physiotherapy, right? You make the patient to swallow.
Yes, sir.
There's a swallowing therapy modules are there. You can make them do that. Or if there is a vocal cord palsy with aspiration is there, then you got to do what is called as arytenoid adduction. Arytenoid adduction, you got to make a bite on the vocal process and stitch it outside. It's a part of when you do a medialization laryngoplasty. So when the vocal cord in a medial position or lateral position, if a vocal cord in the medial position, okay, medial position, you do what is called as when it's in the lateral position, unilateral vocal cord paralysis in the patient in the cadaver position, then patient will not have the voice. If the patient is in midline, patient can have a normal voice. That patient requires nothing. But when the patient has got a lateral position, you will get a dysphonia. So that patient needs to push the vocal cord medially. Do you hear me?
Sir,
Hello?
Can you just... hello, sir?
I'll repeat it again.
Yeah,
Voice
yes,
சரியா
sir.
வரலன்னு சொல்லுங்க.
Voice were breaking.
Yeah,
voice were breaking.
Can you hear now?
Now it's audible, sir.
Yes, when the unilateral vocal cord paralysis is there, it can be in a median position or lateral position. If it's a medial position, opposite cord will compensate and it will go laterally. Patient will not have any problem. They have a normal voice and a reasonably normal airway. So nothing needed for the patient. You won't even identify unless you put an endoscope inside and saw. Okay, but if the patient is in a lateral position, that is the patient who will have dysphonia as well as aspiration. I told you in the morning, the airway and the aspiration and the voice will go against each other. If there is no voice, there will be an aspiration. There's a good voice, there will not be an aspiration. So now the patient has got a lateral position vocal cord. You got to push the vocal cord medially. Once you push the vocal cord medially, the arytenoid also will be lateral. That will not come medially. So you do a surgery called arytenoid adduction. Okay, what you do is you do a medialization laryngoplasty by pushing the cord medially. Similarly, you take a bite on the muscular process and stitch it to the cricoid cartilage. Okay, the அங்க வேணும் மைக் வேணும். Hello?
Yes, sir. Audible, sir. Audible.
Okay, fine. So you see like this. Okay. So when you see like this, your vocal cord will be like this. Okay. That is, the vocal cord will be laterally. The arytenoid will face laterally. So what do? If you take this one, you take a bite on the, I showed you in the morning, this is vocal process and this is muscular process. You take a bite here and stitch it to the arytenoid anteriorly and pull it like this. Pull it. When you pull the arytenoid anteriorly, the vocal process will go posteriorly and close the aspiration. That is called arytenoid adduction.
Yes, sir.
6.5. So this is another case of terminate reduction. There are, when the patient has got a nasal block secondary to any one of these terminate hypertrophy, a lot of procedures can be done. So mainly when we are all young, we used to do terminectomies. Right? The terminectomy means you take out the old terminate like a fish finger and give it to the patient. Patient will be very happy that so much of a tissue is removed from the nose. Okay, but the problem is patient will develop atrophic rhinitis. If not, it develops atrophic rhinitis. Somebody will tell him, they remove the whole target. You are going to. I know one person who has been told in US that somebody has chewed your nose, and he always comes and asks me, hey, chewed my nose, chewed my nose, chewed my nose, like that. So what happens is, it always gives you the bad impression on the patient. So second possibility is you do a partial turbinectomy. Okay, then you got to preserve the mucosa. To preserve mucosa, you got to have a see, this is the hypertrophic turbinate. We did a what is called as
Sir, endoscopic picture is not visible here, sir.
endoscope picture, please. Did you pack the nose? Okay, right. Yesterday I told not to pack the nose. Okay, so this is the hypertrophic turbinate. Do you get the endoscopic picture? Water.
Not yet, sir. Not yet. Yes, sir. Now it's visible.
So actually, you got to infiltrate enough saline inside the nasal cavity.
Yes, sir.
Hey, normal saline தான போடும். So as I told you, you need a plasma to do a coagulator, right? All these times we
Yes,
are
sir.
been operating. Can you hear me, Shankar?
Yes, sir. Yes, sir. Audible, sir. Audible, sir.
All
Very well.
these
Very
times,
well.
all these times we have been doing surface surgeries. So you pour water on top of that, that will work. But here you need saline to create a plasma, but we are going to do a submucosal surgery. So you got to infiltrate saline. Enough saline got to be infiltrated. So I am going inside now. You can see I am infiltrating saline. Okay.
Yes, sir.
பார்த்து போட்டு கொடுங்க. டைட்டா நீல் போட்டியா? Okay.
Yes,
So
sir.
the length of a nasal cavity is 7 millimeters. So you got to infiltrate minimum 7 ml. You can infiltrate how much ever saline you want. You infiltrate more saline, more it will work. Okay. See, second important thing
Yes,
is
sir.
once this should not come out of the mucosa. You got to do the surgery submucosally. To do the surgery submucosally, if you have big turbinates, it works better. Okay, one more.
Yes, sir.
டைட்டா வெளில வராத மாதிரி.
Sir, is this nose a previously operated, sir, or
Previously operated. No. Okay. Once you have done that, pack. Okay.
sir,
Once
your
you have done
criteria?
that,
Yes, sir.
you take, this is called, see, this is the so this is the nasal vent. Okay, the nasal vent has got 3 markings. three black markings are there. So this all three markings should go inside the nasal cavity. So you take it, push it inside, and so all three markings are gone inside. Okay.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
So, hey, Soumya, come and sit here. I want Soumya to come and sit here. That's how my theater people do. You have 2, 3 these things here. It should be on my leg. Okay, so you want to see, I'm going to press this and count 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. After the count of 10, I pull this out. Okay, so this is the first marking. So this will be my second marking. Okay, then another count of 10. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay.
Yes,
Then I take this out. That's my third marking. Okay. Now I do another count of 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. So you take this out, you can see the terminate has become smaller in size. Okay,
Yes,
so
sir,
this will
already-
cause fibrosis, and slowly terminate will shrink in its size. Okay. Hold this.
Yes, sir.
இத கேட்ட மட்டும் கொடுங்க. The important thing is this should not come outside the mucosa. If it comes outside, suction பண்ண மாட்டேன்மா. If it comes outside the mucosa,
Population won't take place.
outside the mucosa, it will cause mucosal ulceration, and you can have sinus K, and you can other problems. Okay, so I pierce, then go inside. You can, oh, it has come out. So go inside a little bit. I already infiltrated. Infiltrate பண்ணிட்டோம்லமா inside. Okay, so one, see that because of the hole it has produced, it's
Yes, sir.
okay. It's count of 10. You can see the whitish area. So that's the second
sir.
one. Okay, so then this is the third one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so there's a, if it is comes out like this, it can produce ulcerations like this. So this will have a little bit of raw area, which takes more time for it to heal. Or if it is like this without any raw area, patient can go to office tomorrow itself. It's only an office procedure. Okay, so
Yes,
this
sir.
will reduce the turbinate well without causing much of a damage to the respiratory function of the nose. Okay, you can keep a small pack
Yes.
inside and then send the patient out. Okay, so
Yes,
this
sir.
is the ideal surgery for doing something as a outpatient department, where you can operate the patient and then send the patient home the same day, and the patient can resume the work from the next morning.
Yes,
Okay,
sir.
any
Yes, sir.
doubts?
Hello.
Sir, your views about co-ablation versus debrider, sir?
For what?
For,
Debrider produces raw area. Co-ablator doesn't produce raw area. And the debrider, it sucks, it doesn't produce, it removes tissue, and it doesn't produce scarring like a co-ablator. Okay, co-ablator you get scarring submucosally. Because of the scarring, it will contract.
Yes, sir.
Debrider you can do with a debrider blade, and you should do it submucosal resection of the submucosal soft tissue reduction. That will be very that will be a good one.
Mucosal preserving.
Mucosal preserving. That is, you got to make a tunnel and put it inside and take it out. It's very easy to talk, but you make a tunnel and put the debrider blade inside when there is a irregular bone of infinite will be little challenging only.
Yes.
Oh. Sir, can you hear me, sir, from OT?
Yes, ma'am.
Prabhu? Yes, sir. Sir, today it has been a very long
Yes,
day.
ma'am.
You have pulled in a
Yes,
big
ma'am.
surgeon, given him a straightforward and very tough cases. even we have given a cordotomy in a patient where the cord was not seen. So even he took it as a challenge, he has done it. I'm very happy, and we want a big applause from the audience for Anthony, sir. Thank you very much, sir.
Thank you very much. It's very happy to be with all the old friends and like old days. So like I have seen everyone who love to see in my life often in an academic area. So I am very happy, and thank you everyone for doing such a wonderful long workshop with a single faculty is very difficult. I know what are all the teaching problem you used to get when you want a transmission. You got to have all these machines should be working. Basically, it's all electronic items. Any day it can work, it may not work. In spite of that, we should thank the God first, because without any major problem, we have finished the whole thing. So once again, I congratulate the GMKMCH team for such a wonderful telecast. Thank you very much.
On this occasion, I also thank Smith & Nephew, a big support of coablation with all their vans, and they have been for a very long time here working for the workshop. Then to Murhan and their co, who has been doing the AV transmission. Then Micro Labs, who have been supporting with all the things, and Sun Pharma, and also Satyanarayan sir and co, Bhavinashi and everyone. If I have left someone, I'm sorry, and I will thank on behalf of our ENT department and AOI
Thank you.
Salem. Thank you.
Thank you, ma'am. Thank you, sir. Now I request Dr. Nagendran, sir. Please, sir. Thank you, sir. Now, I request Nagendran, sir, to honor Dr. Shankar Subramaniam, sir. Please, sir. Thank you, one and all. Today was indeed very great. Thank you again.